So I'd like to acknowledge we have Linda Batch, who is council member for Friends. Thank you. And we also have Agnes Mwangangi, who is the council member for it. Thank you. And we also have members of Kenya Editors Guild. Kindly stand up, members of Kenya Editors Guild. All right, makofi kwa tafadhali, and members of the Kenya Editors Guild Secretariat. Thank you very much. And also, we have members of the media present, our beneficiaries, our supporters, our partners in media. So stand up, the members of the journalists present. Let's clap for them. Thank you very much. We don't walk alone, we walk with the journalists in the newsroom in all our events. So thank you very much and welcome. We would like to thank our development partners, the various institutions represented, for responding to the invite to be present to today's Thought Leadership Series for an important and critical issue affecting the health and development sector. That is funding. But before we deep dive into that, into what we'd like to achieve today, I'd like to give a short introduction of the work of Kenya Editors Guild and the milestones that we'll look at. It is the association for senior editors in Kenya with up to 300 members who are senior editors in the various cadres of journalism, that is television, print, academia, radio, and digital media. And we execute our work through a secretariat with staff running the day-to-day programs to ensure that programs are delivered to the members. Our work cuts across thematic areas, which include membership development, which allows members, which allows the guild to develop its members. So today's meeting is part of our work in membership development, which also offers an opportunity for networking and serves as a platform to allow editors to interact with experts on key issues, and today's issue being health and development. In contributing to the development of the media industry, we undertake training of the next generation of editors and who are journalists, both in the newsrooms and journalists in the journalism training institutions. And this is done in collaboration with the journalism schools with a mission of promoting professionalism and excellence in journalism. We are committed to bridging the gap between academia and industry, and that is why we endeavor to incorporate journalism, the reporters, and also students in our activities. As editors, we also engage community members through town hall meetings, which is aimed at taking the media to the people to allow members of the public to understand what the media does, how editors make their decisions to publish or not to publish. While our work as a media association cuts across Kenya, we have also established collaborations with media associations both in Kenya and in the region. And Kenya Editors Guild currently serves as co-convener of the Kenya Media Sector Working Group, which is a coalition of media actors bringing together journalists and other civil society organizations. And we work to deliberate on the operating environment of media, guided by Articles 33, 34, 35, 36, and 37 of the Constitution of Kenya, which speaks to freedoms of expression, access to information, and assembly. Turning to today's meeting, our mandate being to promote professionalism and excellence in journalism calls us to focus on accuracy and keenness in how we report on health matters and to endeavor to exceed our reporting frontiers as journalists. That's why we assembled today's Thought Leadership Series to allow experts to take us through in discussing the impact of official development assistance discuss on health and development in Africa. So from today's discussions, we would like our development partners and reporters and editors in the room to lead with increased public and media awareness. Journalists and reporters and editors need to be better informed about the implications of the official development assistance cuts. What happens when the aid that we so rely upon gets cut short? And we also want reporters to be equipped to report compellingly on their impact on health and development outcomes, especially in Kenya and in the wider region. From today's meeting, we would like to understand better policy and financing gaps. We would like to identify those through the experts in the room. What are the policy and financing gaps? And how can these urgent gaps in public health financing, particularly around maternal health, child, infectious diseases, programs such as malaria, and highlighting areas requiring immediate attention or bridging support. From this meeting, we also like to reframe the narrative on the African agency. The session advances a narrative to co-responsibly with clear articulation on the roles of African governments and private sector actors and philanthropists must play. What role must they play in financing sustainable health systems? As Kenya Editors Guild, it's our business to report accurately, and therefore from the sessions, we hope that reporters and editors in the room will come out with a bag of story ideas and a lot of insights that will help to better their reporting in health and development. As journalists, it's our duty to verify information and act as a second layer of defense against incorrect information. We have experts in the room. It's our business to ask the right questions, and get the right answers. So as professionals, let us delay the gratification to publish first and fast check first. Noting extremes in funding, as we will realize today, instituted by the development partners, and the dwindling nature of the space, we urge media to embrace collaborations with Kenya Editors Guild to achieve this mandate. We also call upon the development partners to continue to partner with media in trainings, in continuous trainings, in the continuous professional development, in line with our mandate of promoting professionalism and excellence in journalism. And finally, we welcome collaboration with all our partners in the room for our continued programs, and especially on our annual Editors Convention, which will be held in November 2025. Thank you very much for attending this event, and we hope that it will be a great learning process. Karibuni.
Asante. I've taken away something from your speech. Delay gratification to report and get the facts. And there is no better forum than being here today, having access to the experts. And to the next forum, we are joined by two leaders. It's Dr. Moth here. I didn't check, okay. So I'll invite Dr. Willis Akwale. I hope I said that right. I really practiced. Special advisor on ending malaria, who brings deep expertise on how funding transitions affect disease-specific programs that have relied heavily on external support. Karibu Daktari.
Yeah, thank you, Anne. Yes, you got it right. Dr. Willis Akwale is my name. In the past, people will be expecting me to give the status of vaccine distribution for COVID-19. I'm not doing that today. I put on another hat. I'm a special advisor to the End Malaria Council, a private sector-led public-private partnership that is mandated to advocate for malaria to remain high in the development agenda and also do resource mobilization, especially targeting the private sector. That's what I do nowadays under the auspices of the African Leaders Malaria Alliance. But when I was given this short notice, I said I'll really share my experience through my career journey, where, as I've said, I chaired the task force for COVID-19 vaccines. I've also been the head of the Department of Disease Prevention and Control at the Ministry of Health, overseeing the HIV, TB, malaria, surveillance, and laboratory functions within the Ministry of Health. I've been the head of the Malaria National Program, and I've also had an opportunity to serve on various boards globally, the Global Fund, WHO, and CDC. So, looking at the journey, especially in 2003, I actually joined the ministry in 2003, Ministry of Health. During that time, Global Fund had just come in. Prior to that, I had served in the districts then, equivalent to our counties now, and we saw a very big challenge in terms of access. Prior to 2000, a lot of the interventions that we know that would save lives were not available. Working in the districts then, simple things like bed nets were not accessible. Simple treatments for malaria, simple treatments for some of the common diseases, including even things like tetanus toxoids, when you may not know, cats are very common in some of our regions in this country. But 2002 comes and the advent of Global Fund. We get resources to start targeting conditions that really inflict our populations, especially on the African continent, and they are the major cause of death: HIV, TB, and malaria. And for the very first time, we get resources that ensure that there is availability of those interventions. And with these resources, the African countries, Kenya included, start seeing an opportunity to ensure that those who deserve get them. And I remember the very first mass net distribution. I was then the head of malaria. We did it in the year 2006, and we were able to distribute 3.4 million insecticide-treated nets. We were able to monitor the impact, and we actually saw a 40% reduction in childhood mortality, in the deaths from children under 5 years of age. That, although it wasn't a standalone program that contributed, at the same time, there was an increased access to vaccination. Children were getting better. There was, gathering had also come into play. So we start seeing an impact when there is availability. These programs, of course, grew. The amount of money going to Global Fund, I may not have the figures now, but we saw that grow, and that is, it grew. We moved from just making these interventions available to what we call universal access. We wanted to reach maybe 80% or more of the population to have even better desired outcomes. And during that time, yes, funds were flowing. You could literally say money was flowing through our ears. We were not thinking there would be a time that would stop. And during that time, in many of the grant applications, we were always asked, how are you going to sustain what we are doing? And we always used to put a footnote and say, sustainability was always the last paragraph of the application. We will talk nicely to our governments to put some money in the budget. That's what we would always say. We would always say we are going to look at the issue of local manufacture. We would always say we are going to do some fundraising activity or the other. But the truth of the matter, we never followed that seriously. And another year would come and would repeat the same things. Now, but as we went along, of course, the donors started telling us, now there's a plateau of the resources. And the word was, stretch the dollar as much as possible. We are giving you the same money like we gave last year, but we want you to do more with the same money. And people started becoming innovative on what they needed to do. And we therefore started seeing programs that were geared to deliver at some fairly reasonable cost to ensure that the interventions reach those who required them. And these programs multiplied, and some of them, looking across the continent, were more expensive than others, and there could have been reasons for that. But definitely there was a worry that some programs were becoming too costly to be sustained if the donors pulled out. So I want to reflect on two areas to really answer some of the questions on the impact of the severe reductions in the ODA. Now, when I really look at the programs of HIV, TB, and malaria, mainly supported by the Global Fund, one of the things I reflect back and ask, what was the unit cost in terms of program delivery? We quite often look at the intervention, the supplies, or call them the health commodities. How much is the malaria medicine? How much is the ARV? How much is the TB diagnosis? That we look at it and we are able to say maybe $1 to treat malaria, $2 or $5 to treat HIV. But for you to effectively do that, you need to have an effective program. You need human resource. You need the health system to be ready to do it. You need a very good monitoring system so that there's also accountability. You also need to be innovative, and you also need to look at some kind of research. So the question is, were we doing some of these things when the money was flowing? I'm afraid to say we were not doing them, and even if we were doing them, not to a level where the impact could be seen today. We would have done better when the money was there. And even now, we may need to do some of those things. And I reflect on the issue like, for example, local manufacturing. If we get some of the commodities for HIV, TB, and malaria produced locally, now we would not be in the situation we are in if we had started local manufacturing. And indeed, the private sector was eager to do that. But, of course, there have been challenges with local. And the question is asked, if they produce locally, and is the government going to buy those commodities? Or are we still going to prefer commodities from all over the country? Do our local manufacture meet the set standards by international organizations like the Global Fund, World Health Organization? For a long time we asked ourselves, even condoms. Do we produce condoms? What's our utilization? There was a time I knew assure us, give us incentives. That has not been quite well managed, and I think if we did better, we could be in a different position now. Then there's always the change of technology. You are dealing with this category of medicines, there's resistance, you need to move to another category, and local manufacturers have started producing this. Now the world is moving in another direction. Were we positioned to ensure that technological transfer keeps us ahead in the game? Now, when it comes to research, because that was also time money was available for research, what was our priority in terms of research? Was it to impact immediately, or were we also doing research that benefited the industries in the developed countries? And I remember in one evening walking, we were stuck, our vehicle had mechanical problems, and we looked at some school children walking home back from school in the evening, and when we looked at their eyes, we could see they have anemia. It was in a malaria endemic area, but potentially they also had mumps. And the question was, don't we have enough knowledge to even ensure that we do research to produce effective medicines dealing with both malaria and ones that cause anemia to school-going children. So these are some of the things we looked at that time. Now let me then share my experience as the chairman of the Vaccine Task Force, and here I will just say 3 things as lesson. In that global pandemic, one of the things we realized is that because of modernization, because of travel, diseases can spread so fast, so quickly. Somebody may have traveled from America today evening, they'll be here in Kenya, and there could be a new pathogen already available. So, and we say nowadays diseases spread as fast as the aeroplane. And with that, then the question comes, how better should we be prepared? We cannot live in isolation. In all health matters, we need collaboration at regional level. We also need collaboration at global level. Health cannot just be left to countries alone. Because, of course, the borders are not any fixed structure. They are porous, people are moving, and as I've said, with better travel mechanism, pathogens will just travel as fast as that. So within no time, when pandemic was there from China, I mean every country globally within a month or 2 was reporting cases. Now the other lesson we learned during that is that when travel and transportation is impacted, then even if you have money, you may not have access to some of the supplies you need. You remember there was a time countries could not have access to PPEs. Countries could not have access to the vaccines. A lot of lobbying, a lot of advocacy work had to be done, a lot of almost begging so that we could also start vaccinating populations in Africa. So, and that points to the fact we must think outside the box. One, look at local manufacturing, but also have a global discussion where we want to shift market dynamics so that some of the production of these commodities actually happen where the burden of disease is. Why should we be manufacturing malaria medicines in China that has eliminated malaria and not on the African continent? Same with TB, the diagnosis, HIV treatment, and preventive measures, as I've said earlier. So we must start really thinking that we must bring this because it's the only way we are going to reduce some of these costs. Now the other lesson, and this is going to really imply on the current reduction, and I'll come back. Once you interrupt supply chain is a very sensitive thing you have within the health and medical services. You have to order things, the tendering process takes this period, whatever. By the time you are getting commodities to the communities, estimates give it 9 to 12 months. In our setup, it could take even more than a year. And once we interrupt that because either there is no money or like there was the global pandemic, that access then is affected. And that's why in the newspaper quite often you hear now we don't have this vaccine, ARVs have run out, we don't have something for TB. Once you interrupt that, it's not going to be magic even when you get money, that within a week or 2, everything will be back to normal. So we learned that during COVID, you must ensure supply chain is not impacted even when you have a pandemic. Now, the other thing we learned, and this is my very last one before I make some general observation. During COVID, there was a push that we start local production of vaccines. We did our best. We went to the cabinet, approval was given, that led to the creation of the Kenya Biovaccine Institute, which is now up. But as we were doing that, we realized that technology may not be the most difficult part of vaccine production. But what was a biggest challenge is the market for the same. Once you've produced those vaccines, where are you going to take them? will you consume them only as Kenya? Then the vaccine institute is not going to be sustainable. And what determines the market? You start realizing, yes, the market is globally controlled. Gavi procures almost maybe 70% of the vaccines globally. So if you're not at the table with Gavi and you can't get your vaccines meeting the standards and being also distributed through that mechanism, you are going to end up after putting a lot of money into expired stocks. So again, the issue of regional collaboration, even as we look at manufacture, that you are targeting a market that can sustain the business, is a lesson we learned when we really looked at the issue of global vaccine manufacturing. So with that experience, I was asked, how does disease funding affect a number of the issues in the health sector? And I would want to look at them as immediate, midterm, and long-term. And this is a question being asked especially from early this year with the severe cuts from the US government. But prior to that, many other countries had actually reduced funding. It just didn't begin this January. And the projections are the funding is going to be further reduced. And when we quite often listening to many forums, people say, no, the impact is not big, we are going to manage. But they don't give any specifics. From where I sit, some of the immediate impact I can tell you, with this reduced funding, many organizations that had employed some of the best brains in the health sector, some of the most progressive people who really wanted to contribute to this country have had to lay those people off. Some of the best brains in the health sector are now on the streets, so to say. Because the organizations that had funding used to give better terms. Many of the best people went there, and now they are out of a job when they should be contributing to the development of this country. That's immediate. Of course, other immediate things, the hospitality sector has been affected. Maybe this room used to have better occupancy than it has now. The conferences used to be more. The airline industry used to get a lot more. Taxis, there was a lot of money flowing there. Those are some of the immediate things we are seeing. But like what I said, there is also now disruption in the supply chain. In the now medium, there are some maybe even immediate, but in the medium and long term, that is going to start coming out. And when these interventions then are not available to the communities, we are going to start seeing impacts on health in terms of mobility. That is the number of sickness, those who are coming down with some of the diseases we have controlled. And we are therefore then going to start seeing an increase in the number of deaths. If we don't have enough malaria medicine, there will be more people reporting to the health facilities, there will be more admissions, and there are going to be deaths, especially vulnerable populations. Same for HIV, same for TB. So we need to start looking at them in that way and better prepare. And of course, immediate, medium, and long term can come in very quick succession. Now the other thing, and I need to, this is my very last projection. How ready is the health system when the funding cuts happen to adopt to some of the recommendations that we are going, that maybe through discussions are going to be recommended? And I reflect back during COVID, when we needed oxygen, which then became so useful commodity, we realized really a lot of our facilities could not administer oxygen. They didn't have the capacity for production. We even didn't have policy guidelines on what type, how we deliver the oxygen. But through that crisis, we learned a lot of lessons, and oxygen became available. But have we sustained what we did at that time? Because oxygen is an important medical supply. What proportion of our facilities now have that in place? So the overall readiness of the health system, how do the funding cuts impact And how ready is the health system in terms of innovation to move forward without a big impact even within the funding cuts? I don't have an answer to that, but ladies and gentlemen, I just wanted to reflect. I had nothing prepared, but when I was told, please come and share your experience, I've just put some of the high-level things I experience working, have experienced while working within the health sector in Kenya. Thank you very much.
Asante sana, Daktari. I think that is a sobering, heartbreaking reflection. You know, when you sit on the sidelines, you never imagine that, you always imagine the people up there, you know, those experts, you always imagine they have your best interest and they're definitely looking through these things and making the plans, fortifying the future. But it is good that we're having this conversation now, because it gives us an opportunity to pivot and to reflect and to chart our way forward. Next, I'm going to invite my longtime friend, Eric. Karibu sana. He's going to take us through data, previous programs that have worked. How can we work with these to make better our storytelling? Karibu.
Thank you very much. Good morning, everyone. So yes, my name is Maxi, Eric Gitao. I might just need a bit of tech support. Data is shared through visuals, and that's sort of what we try to do as we speak. But today, I'm here also in a different capacity, as a father to a Gen Z, and as a father also to a Gen Alpha, and they're here. They came with me because they closed school yesterday, and interestingly, they too have been a month or two ago, they had been invited by Total News to talk about funding disruptions from the lens of children and their future. And so they are part of the conversation, but from Total News. In this regard, I request that we, of course, do not, we safeguard and we do what is important when it comes to child protection. So this is an exciting conversation that we are having, and I want to begin first just by acknowledging that we are living in a time of a lot of dysfunctionality, a lot of desynchrony, and a lot of disappointment. And when I say dysfunctionality, what do I mean? Think about the systems that we operate in. I think you've heard from what has been mentioned. The question you're asking is, are the systems, even the health systems, but also the funding pipelines, the funding systems, the governance systems, are they working the way they should? We see a lot of dysfunction in the disconnect between the global funding priorities and the on-ground. And I think we're already beginning to hear how that looks like. The on-the-ground needs in the communities and in the continent. As a matter of fact, we see this in very complex. And when we are talking about ODA, when we are talking about the official development assistance, there was also a bit of opaqueness. And I guess by the time the declarations in January were being made, part of that was to be able to streamline access properly. Because it has the dysfunctionality is that we don't always have the resources directly benefit partner countries, and as our data will show, it's this very clunky machinery of development finance that often feels very sputtery and not soaring. We see desynchrony in the sense that there's a lot of things that are out of sync. There's a lot of replication. There's a lot of things that are also out of time. There's a lot of mismatch between what is urgent, what is evolving health and development challenges that we face. And right now they are made further complex because of the climate change impacts that we are seeing, because of the persistent inequalities and also new health crises that is also added into the slow and very often reactive pace of funding and policy adaptation. It's sort of like trying to address the 21st century problems with 20th century tools and timelines. These needs are immediate, but often the response can feel very delayed and out of time, out of scope, and very slow. But we also see disappointment. And I'm talking about disappointment hits home for many in the sector. You've heard that people have lost jobs. Truly, colleagues that we worked with who have led very important initiatives that are life-saving. They are no longer able to contribute to the sector. Their dashed hopes when promised funding doesn't materialize or when impactful projects are cut short due to financial instability within the organization, but also more broadly within the sector. So there's a frustration in seeing years of progress threatened by sudden shifts in donor priority, by the global economic volatility that exists, and there's a quiet sigh when a brilliant initiative that has been formed through the processes that are necessary, it then can't take off the ground because the funding landscape is uncertain or cannot adequately fund that. So when you talk about dysfunctionality, when you talk about asynchrony and disappointment, we are seeing these not the first step to begin to reframe, to reimagine, and to resolve them. And we, together, collectively, will need to look at the eye in the beast, understand its nature, and then figure out how to tame it, or better yet, how to transform it. And this is the context for Development Dynamics, the organization in which I am privileged to be the lead. We are a lean team of African self-determination. We are an Afrocentric, proudly. We are Pan-African, and we are also working towards impact and just to disrupt the development, social impact, and philanthropy ecosystems. And we've been trying to do this and to meet the moment in three ways. And one of those is through our think tank, where as an insights hub we've been curating and producing knowledge and intelligence, some of which we'll be sharing today. As a do tank, we've been co-creating strategy with various organizations, supporting collective capacity, and also how to measure and tell impact. And as a through tank, we've been convening, connecting, and catalyzing resources to various streams across the sector. And what makes us unique is our triple play approach. I think when we are here in the room, we think who is affected the most. That's usually the user, the person in the community, the person who has the need. When you're talking about the health system, you're talking about the person who needs their health safeguarded. And therefore, it's important to deeply empathize with them. It's important to deeply think about the system, the ecosystem and the interconnectedness of issues that, that make their everyday reality. And it's also important to check out what their foresights are going to be. So, in the recent past, and building on this, when this year hit, in the month of January, organizations, including ourselves and most of yours, were firming up our annual plans. We were fixing budgets, we were getting ready to take off. And then, boom, a new US president is sworn in on was it 26 or 16? And alongside is billionaire sidekick, they decide that we are going to pronounce a stop work order. And just that one sneeze in Washington, it became not just a cough, not just a flu, it became a global pandemic again. We felt like we have returned to 2020. And the number, I mean, we had been seeing what the declines had been looking like, but this was a massive one. And shortly thereafter, other European countries also began mentioning that they are going to follow suit and start giving timelines. While for the US government was immediate, the rest also started giving timelines and reductions with words like work towards self-determination. So what did we do at Development Dynamics? At that time, we conducted in all of February and March, working with the East African Philanthropy Network, we conducted a rapid assessment on the impacts and adaptations to these funding disruptions. We collected and analyzed data from 235 organizations in East Africa who are reaching millions of people in interventions, especially in health, and then health plus. So it could be in health, health and education, health and livelihood, health and climate, health and agriculture, etc. And our findings, they began showing the acute pain point that many African development organizations are feeling due to these recent and very severe funding disruptions. We began examining the direct correlation between the funding cuts and the impact on the mandates of these organizations. And ladies and gentlemen, it's not just about losing money, it's about losing the ability to serve communities in their millions. We saw and highlighted some effective adaptation strategies, resilience that goes beyond just survival, and our report, which we will gladly share after this, shed light on some organizations and how they're adapting and taking strategic action in response to these funding changes. And a few of them were taking anticipatory action around strengthening what we call the 5P framework, which is private, public, philanthropy, people-powered partnerships. And speaking of partnerships, we also work next with the Wings Foundation and the African Ventures Philanthropy Alliance, AVPA, where we undertook a 3-month study, just again in this year, early in this year, between March and May, on what we call the Pan-African multi-stakeholder partnerships ecosystems in our region. And this particular study wasn't just about who we are partnering with, it was actually a key focus on exploring the strategic deployment of what we call catalytic capital. And our question is, how do we de-risk social investments, health investments, to attract the private funding that is important, that is desperately needed? It's about shifting, as we are saying, shifting the narrative from aid and from charity to very strategic investment in the different pipelines around health. So crucially, this study had us also do a deep dive and analyze power dynamics. Power dynamics is something very important, and interdependencies between various actors. We are seeing venture funds, we are seeing foundations, individual philanthropies, and the international entities. But let's be honest, the elephant in the room around power dynamics, it's who actually dictates funding flows, and more accurately, where does it flow towards? That's an important question. So we need to understand that the hidden currents to truly influence change. And so most recently, just ahead of a recent Adolescent Sexual Reproductive Health Conference in Mombasa, and also the International AIDS Summit in Kigali last month, we published this groundbreaking SRHR funding outlook for 2020. We need to anticipate, not just react. So we identified that major development partners and the broader development trends, the geopolitical shifts, issues like the anti-SRHR movements, these things are directly impacting funding and where it's going. And our goal in this research was to propose strategic considerations for the East African-based actors in health. And the questions that we are asking today: how do you adapt when the ground is constantly shifting from beneath your feet? This particular research also is important because it offers some navigational charts for us to consider. I'm excited to also mention that we are in the process of working on a paper that is in progress. It's a landscape of innovative financing models for sustainable development goals, and we are particularly leaning on health. And this is our proactive step towards resolving the challenges that we've identified, continuously seeking new ways to ensure that the goals amidst the global desynchrony and disappointments are not being assumed. So, question is this is one of the reports that I've spoken about. This is the other, and I will share a QR code at the end. And this is the other one that I just spoke about. So these three will form. I will consolidate shortly just a few highlights from that we have triangulated from these three. And my colleagues Nicholas and Felshia, they are here somewhere. Yes, Felshia is there, and Nicholas is somewhere. All of us are available to deep dive into this a little bit more. So let's see what this data actually tells us. Now, our data is telling us that around 21% of organizations are at risk of losing 75 to 90% of their funding. This is all the research, or the combination of all of what you've spoken. Now, only 8% are saying that they can navigate properly. It's not just about reduction. There's a pretty clear existential threat. And then when we look at ODA, which is a conversation that today's roundtable is addressing a lot, we see that over 18 or close to 19 billion euros of the ODA reported in 2023 did not directly benefit partner countries, and East Africa particularly has some concerning amounts that we could be looking at. These funds counted as aid, but often covering donor, refugee costs or imputed students' costs. They obscure the true level of genuine assistance that is reaching the ground. And so what this actually means is that the resources for critical programs like health are far less headline figures, they are far less than the headline figures actually suggest. And the organizations here that in the room that are bearing the brunt of that a lot. And what's more, where there is a stagnating or declining proportion of overall ODA specifically allocated to SRHR, it then has various other implications. We also seen that when we face these challenges, the role of crucial contributors within philanthropy, like Gates Foundation, who had contributed close to 40 million to UNFPA, NANCO last year, and Amplify Change, who had provided some vital grants for health advocacy work across Africa. This philanthropic support is crucial to ensure that we can continue getting the gains. On a more positive note, bilateral donors like Canada, who emerged last year through their various mechanisms as a proactive donor, they announced around 250 million in new projects earlier this year. And fortunately, most of those were directly targeted towards health, and especially adolescent especially sexual and reproductive health and rights. So, if we sit and just try and triangulate that 21% of our organizations that face severe funding, and then a significant portion of reported aid not reaching its intended destination, how can we then collectively advocate for more, not just for more funding, but for smarter, more transparent, more impactful funding? What role can the media play in this? What role can the different partners who are in this room play to ensure that every dollar counted as aid actually genuinely drives the demand on ground? Additionally, beyond the direct financial figures, our research also has highlighted several compounding dynamics that are shaping funding, especially in 2025 and moving into next year. Already most countries whose new financial calendar starts in June of this year, in July, of this year, we're already living in the 2025-2026 era. These are the underlying currents that will dictate where the flow of resources and the viability of our development work. First is just this drop in financing across the aid system. I think we have seen what that has looked like for not just UNFPA, that's just one, but the global needs are increasing and they are soaring, and it's a critical focus that we have to see how we can tighten our resource environment. The rise of populist governments and increasing humanitarian demands that are driven by conflicts in places like Ukraine, like Sudan, these are fundamentally altering also where resources are going. Aid is now being diverted to more acute crises, often at times at the expense of health. And perhaps more alarmingly, we are seeing the intensified efforts of, in this country, perhaps anti-rights, anti-reproductive rights, anti-sexual rights movements. These are well-funded, intentionally coordinated efforts that are actively working to undermine policies and funding. And this introduces some ideological threats that go beyond just funding cuts, because it's about politicizing critical health decisions. And given these profound shifts, I think, and a shrinking aid pie, competing global crises, the direct ideological attacks, what is our collective strategy to not just thrive, rather to not just survive, but to actually thrive? And how do we ensure that collectively, including with the narratives that we tell, that essential development work, particularly in sensitive areas like health, in life areas like the ones we've been mentioning, is not sacrificed at the altar of geopolitical expediency or ideological agendas? We did a deeper, in-depth analysis across Kenya, Ghana, Nigeria, and Senegal that involved a lot of key extensive informant interviews, and there are things that we are seeing that are critical, 3 things that we are seeing that are critical and interconnected. These are trends that we are seeing that are defining the African philanthropic ecosystem and how we must respond to funding disruptions. We are observing a distinct and accelerating movement towards hybrid organizational models. And this means that organizations, including those who are working in health and those ones who are working alone, they are no longer solely landscape is indeed turning upside down. We witnessed, what we are witnessing are not just minor adjustments, we are witnessing fundamental shifts in how capital is being mobilized. So we are seeing impact investing rising, we are seeing community-centric fundraising becoming a big thing, platforms finding their niche, outcomes-based financing growing, collaborative financing models becoming standard, and match financing as a key thing. And I'll skip this so that I leave you with some food for thought and conversation after. But I'll say that there are big changes ahead. And these big changes, because of where we are at, they require a fundamental shift in terms of how we think. We require big budgets to move the sort of health disparities that exist. We require to look at stuff from a multiple lens. We require to take big bets and move capital. We require to address big challenges. We require to move along the big shifts and big innovations and big collaborations, and also to evolve in our language, and this is where the media plays a key role in helping to highlight some of this. And so given what we now know and what we also do not know, I think it's time for us to ask ourselves, how do we change and how do we transform? And what happens next truly depends on where you see yourself and where you are in this ecosystem. I leave you with a challenge to just look on screen and identify what you can do. Every one of us here can play a role. You may be a convener that's bringing, this kind of convening together, but also with others. And that's a critical role that needs to continue playing. There are researchers like ourselves and advocates like people who are here in the room. There's one here that I like a lot, I call it stalker. We have to keep our eyes and ears open to opportunities and take advantage of them. See where the leverage points are and enter and address them. But we also have to keep building capacity, and maybe a few of us have that mandate. And as I go to sit, I think I leave you with just that food for thought. In the kind of evolving landscape that we are finding, that funding disruptions have brought, there's also a lot of new opportunities. Which of the roles that you saw there can you play, or are you playing? Or are you already equipped to play but maybe haven't yet started playing? How will your own unique contribution ignite the kind of change that we are seeking? The QR code that's here leads you to the reports that we have, and feel free to access them. And I appreciate the conversation that is about to happen, especially grounded on data and reality. Thank you very much.
Asante sana, Eric. Yeah, I think you bring to the four important conversations that we must have: smarter spending, holding power to account, on the part of journalists, going deeper than what is on the surface. Next, we are going to have a panel, and yeah, she's back. Okay, so I'm going to invite you, Dr. Rose Oronje, come over, introduce yourself, and take a seat.
Good morning, everyone. As she said, I'm Dr. Rose Oronje. I work at the African Institute for Development Policy, in charge of public policy and knowledge translation. Happy to be here.
If I'm breathless, it's because I've been told tea is ready, so I'm really trying to hurry. Dr. Gilenji Getahi, come on.
Okay, as she said, my name is Dr. Gilenji Getahi. I'm the Group CEO for AMREF Health Africa. Thank you.
This one. Yeah. And I just want us to have a conversation we've heard from the different speakers. And I just want to throw this to you, to the both of you. African governments spend on average 7% of their budgets on health, well below their Abuja declaration's target of 15%.
How do we then have honest conversations about domestic accountability while also critiquing donor behavior? And this is in hindsight of, you know, what we had from Dr. So really, how can we be here, you know, discussing this while even the budget allocations are way below the target?
Okay, I can start?
Yes.
Okay. I will stand up because this is blocking me from the people on that side until it's moved. Is that okay?
Yes.
Yep. Good morning again. Good morning.
Good morning.
Okay, thank you. So, I think we first need to get some basics right. Because as the media here, and I've been in media myself, we have certain notions we need to first clear so that we start afresh. The first thing I like to say is that 15% of a chicken you could say about $5 billion a year. But where does it come from? It comes from taxes, which is what we are asking to be 15%. Right now, it is 7%. Then it comes from individuals, you and I, and the Harambes, and the money we pay when you go into the pharmacy and all that. That's out-of-pocket expenditure. And then a small part comes from the reason we're here. And the reason we're here is organized development assistance. But when you look at that 550 or 600 billion, we can use 500-600 billion for argument's sake. The conversation that brings us here is only 20% of that 600 billion. Only. But that seems to be the focus that we've been having for everybody. So that, out of the 600 billion, only about 120 billion of that is organized development assistance from US, Gavi, Global Fund. The other balance comes from the government and individuals. And actually the individual contributions from out-of-pocket expenditure are more than the combined aid. So health in Kenya is not funded by USAID. Health in Kenya is not funded by Global Fund. Health in Kenya is not funded by Gavi. It's funded by the government through our taxes and our pockets. Now, let me come to the, so, you know, I'm getting back to this because they're saying that the question is about why we can't achieve the 15 yet we are holding donors accountable. That's what I'm trying to answer. So, the first thing we need to agree is that we fund our health care. The donors only support a little part of it, which is anywhere 20 or less. And that's across most countries in Sub-Saharan Africa. So let's come now to the question of, if we achieve 15%, will we fund our health care?
Could we?
No, we can't. We cannot fund our health care, and I'm being very particular on care, because our understanding of this conversation is from a health care lens. It's from hospitals, machines, and drugs. I'll tell you that in Kenya, let's assume we achieve 15%. Let's start from there. So if we are to achieve 15%, the Kenyan GDP right now, if you took the Kenyan GDP, which is just about 100 trillion or so, if you took that, and then you actually applied tax, because the 15% is money from tax, is how we fund our budget. If you took tax, Kenya taxes its GDP right now at about 18% of the GDP. That's what the president has kept saying, we need to raise that to 25. That's the fight, Gen Z's and the finance bill. Because the president keeps making it sound like we can actually increase our tax efficiency. In most African countries, we tax at 14-15%. Why? Because our economies are informal. You know, it's very difficult to tax your hairdresser, my shoe shiner, and all those things. 80% of the population is informal. Now, if you compare that with a country like Germany, 80% of their job is formal. So it's difficult to actually match our tax efficiency to formalized economies. But assuming we did, and we taxed at even 25%, which is almost impossible, I can tell you, almost impossible to raise our tax to GDP to 25%. But assuming we did, then you tax that GDP total, and then you allocate 15% to health. Do you know what you're going to end up with? You're going to end up with $50 per person per year. At best, taxation, which is not possible, that's 25%, and at best allocation, which is a question you ask, no 50% Abuja, you'll end up with $50 per capita. If you did exactly the same math for Germany, which is 25% taxation, 15% allocation, you'll end up with $5,000. Okay? Now, with $5,000, Germany can fund health care. That's why health services are free in Germany. You can go, the government tax as well, and allocate $5,000 to health. So meaning that whether you have hypertension, diabetes, you'll get all your services. How can you do that with $50 in Kenya? How can you do the job of $5,000 in 50? It's not possible. So I think the point I'm trying to make here is that we need to shift the conversation from Abuja. Because even with Abuja, you will not fund health care. It's not possible. We must shift that conversation to building health. And building health means we recognize we don't have money, we will not have money. The projection we have from World Bank is that we'll only raise the $50 of tax money to $100 in the year 2100. So we can't actually afford a healthcare model of Germany, of the UK, and Europe and US. We can't. So we must shift this conversation, fellow media person, from the 50% Abuja to how we can make our people healthy. How can we actually produce health? Because there's no amount of money that's going to be able to provide health care, where health care is treatment based. I just wanted to frame that, and I'm sure we'll have other questions about aid and how to move from there.
Yeah. Let me first come, I'll come back to you. I think I have a follow-up question on that. Let me come first to you. African regional bodies like the AU make grand declarations about health financing. But from where you sit, where does our power as a collective lie?
So thank you very much, Anne, and thank you, Daktari, for bringing those points up. I think I'll just respond to that. First of all, I want to react to what you said, and saying that we shouldn't think about our healthcare the way the West thinks about their healthcare, and that's what Daktari has said, and that's the reality. That's part of the reason why we are where we are, because we're thinking that health is the hospital, and we're thinking that we are going to fund it from taxes, and yet health is not the hospital. Every day, but we have built a system where we're waiting for Rose to fall very sick. If I had those terminal diseases, cancer, it's picked up very late. At the point it's picked up, there's so much money that is needed, and you're managing me as I die, right? And yet those things, if we could look at health holistically, because health is not a facility. Health is everything I do every day. Health is in how we do our agriculture. What are we eating, right? How are we changing our food systems? Health is roads. Lots of people die on the roads. How do we manage those? Health is what are we teaching our kids in school? So we need to shift to look at health holistically, and therefore look at what do we need to do, apart from the monies we are talking about, to look at health, to look at an individual holistically. So that we are preventing me from getting to the hospital when I'm very sick, and enabling me to own my health and live a healthy lifestyle. So I think that's very important of what you brought up, Daktari. And I think the issue of, we've kind of left health to foreigners, and that's part of the reason why we are here today. There's a lot of over-dependency. And that Dr. Ahwale said, he was talking about how things changed in 2000. When a lot of donor funding came in, which was great, and it has had a lot of impact on improving health, right? Health outcomes.
But how do we move away from our dependence? When you look at data, you see a lot of countries, and now I'm coming back to your question around Africa and our power. You look at countries in the region, a lot of them depend
depending on donors. We will never solve our health problems that way. It means we basically said, let's put in very little, let's let foreigners handle our health. And so as African Union, regional bodies like African Union make those declarations, sometimes you look at them and the declarations are made out of good faith, but really we need to have honest conversations. And if we do have those honest conversations, we'll probably be making very different declarations, right? Because when we talk about the African Union right now, they have a commitment around, that has been made by heads of state. They call it the ALM, the African Leadership Meeting Commitment, around enhancing investments in health, domestic investments in health, which means their own investments, but also spending that money very well. You know, that is a conversation that has been going on since 2019. Of course, it was affected very much by COVID-19 in 2020, so it kind of stalled, and the conversations are now picked up at the regional level and at country level. We have some conversations even in Kenya on that. Who is driving that? And it comes back to the power dynamics that the earlier presenter was talking about. Are we doing that as African Union because we are partnering with some funders to do it, or are we doing it because we are looking at our health systems and stepping aside to say we need to honor?
As Africa, we've been doing some studies on inefficiencies. What are the sources of inefficiencies? Everyone talks about wastages, leakages, corruptions. There have been estimates talked by UN and even the World Bank showing that Africa could save $9.5 billion for health if we addressed corruption and leakages. Yeah? Issues of wastages in terms of absenteeism in healthcare workers, ghost workers, those stories are in the media, not just in Kenya, across the region, where we are paying a lot of money to people who are not working. For me, the question is, these are our systems. We have the power in our hands to address corruption. We have the power in our hands to address leakages. We have the power in our hands to address the wastages. It comes back to, are we really willing? Is there political will? Are we driving this health issue, or are we just speaking because some external people want us to speak that way and we say that way? We are not in power, we are not driving our health, and we need to do that. Looking at it holistically, but also tackling all these inefficiencies that have been, there are numbers to it. That we know where the inefficiencies are, we know where money is being wasted.
We need to wake up and close those gaps and stop talking about reduced ODA, because ODA, even if it's increased, is not going to solve our problem. We're going to solve our problems ourselves by addressing the challenges that we have and looking at health holistically.
Okay. So, solve corruption, come back locally and try and resolve the health challenges that we have. Let me come back to you, Doc. How much of the current crisis is actually about just poor planning, and what are you seeing from where you sit? Can you give us the unvarnished truth about what ODA cuts actually mean on the ground for you and the programs that you oversee?
So as I say, the total ODA in Kenya is about $1 billion in total, give or take, maybe 1.2. It's about $1 billion out of Kenya's total health expenditure of $5 billion. So we're talking the 20% I talked about earlier. But because this 1 billion is very concentrated in particular diseases, as Dr. Akwale said, the impact that we are seeing is in those areas that were focused, the 1 billion was focused on. It was focused on HIV, tuberculosis, malaria, and maybe maternal health and child health because of the relationship with the transmission of HIV from mother-to-child transmission. So that's the area. Now, therefore, and then what happened was that within that 1 billion, certain neglected systems were taken up by the 1 billion. That means data systems. So the Kenya Health Information System, a lot of it was funded within this 1 billion, because those are the people who are more interested in the data. So they supported it to get their data, okay? And number two was that because they wanted focused, concentrated care in the areas of interest, they also hired health workers for those concentrated areas of interest. Because they didn't feel the general health worker will address their data need and their concentration need. So you find that there is a big impact on the areas of concentration, HIV, TB, malaria, and maternal health. But there is also an impact on the general health system because the other system they had also sucked in, and that is the health workers. The health workers that were released across Africa, we estimate, is about maybe 350,000 health workers across Africa. In Kenya, I've had different numbers. So those are the ones that Dr. is saying were fired, and therefore they're outside there, but we're in the system, in the county systems and national systems. The recovery of the data, I think has taken some time in some countries, have not been able to recover it. In some other countries have recovered. I don't know where Kenya is. Probably everybody has more information about the recovery of the support for the Kenya health information system. The other thing was supply chains. Because whereas KEMSA exists, there was a lot of focus on supply chain for the particular commodities that were meant for those areas of concentration. So whereas the donor assistance was only 20% of the total $5 billion, it collapsed the other $4 billion because of the system they had sucked in. So what we are seeing ourselves, I'll give you a case of South Africa. We work in multiple countries in Africa. Our total expenditure per year is $250 million across the continent of Africa. $250 million. In Kenya, that would be about $50 million. Out of that $250 million, our funding of US government was about 20%. So about $50 million was US government, PEPFAR, CDC, all different ones combined. So they took about 28 million of that dollars. So what happened after that? Of course, we let people go, about 140 people who were directly in the program that were closed. But the rest of the money remained, funded by the Gates Foundation, by Wellcome Trust, by MasterCard Foundation, and others, and also our own money that we raised. There's something Maxi said. He talked about the hybridity of funding and sustainability. What we have done as AMREF over the last 10 years is to actually increase social enterprises within the organization. We have two key social enterprises that actually contribute money to our $250 million. One is AMREF Flying Doctors. The AMREF Flying Doctors franchise, which is what we used when we started of doing evacuations and flying doctors around the country and around East Africa, became a social enterprise because from 1957, when AMREF was founded here in Kenya, by the way, AMREF was founded in Kenya, it is still headquartered in Kenya globally, and even when you have offices in Germany and everywhere, they all report to Kenya, Nairobi here. So it's actually a global, it's the only international NGO founded and still headquartered in Kenya. Out of these activities that we started with, which is the flying doctors, now we have about 5 aeroplanes, but they no longer have to fly to Loitoktok. They no longer have to fly to Tanzania. Why? Because the road infrastructure has improved. So when you take a doctor to Isiolo, it's easier to get them on the road. But also you may not need to take a doctor there because now they are doctors with devolution and all these kinds of things. So what we use that infrastructure to do? To sell Maisha cards to you and to also cover tourists who come to Kenya so that if they have a problem in Masai Mara, we can evacuate them. Out of that, we raise about $25 million. And out of that, maybe a profit of 1.2 million or 1.5 million, which comes to support our work. We then have the AMREF International University. It is started from our work of training community health workers, nurses. Finally now, it's developed into an institution with 4,000 students who are paying fees. We are still training nurses that are needed in Africa, midwives, are trained physiotherapists, but because the economies have grown, they are paying their own fees. So out of that, we are running an entity of close to $10 million that is financed through cross-subsidization. Those who can afford to pay fees, those who can afford to give them scholarships, but it's not dependent on donors. So out of our $250 million, if you are 25 and 10, that is $35 million, which is not dependent on donors. It is actually dependent on economic growth, public-private partnerships, and contributions of families that can afford, and then you cross-subsidize. So I'm a flying doctor, we still go to Mandera and evacuate a poor family. but that's not funded by a donor. So this is what we have done ourselves, so that we are less and less dependent. And I think that is what we need to look at moving forward. But remember, the challenge of what you're asking is that the 1 billion I talked about is where the most pain is because of verticalization. If we had actually integrated around that 1 billion into the general health system, we would have felt a financial drop, but not a system disruption. And that's what Rwanda has done, integrated the aid money into the national financing budget, so that any drop may be a pain in financial drop, but in terms of systems, they're still holding together.
Okay. If we were to say we want to resolve the current gap that we are facing as a country, as a continent, what would we need to do urgently to fix?
That's to me.
Yeah.
The only way to fill that gap is to reduce healthcare expenditure. Let me explain that. I talked about the dynamics of Kenya's and Africa countries' fiscal space. There is no money. That's the point we need to. Africa, Kenya, has no money to provide for the current healthcare model. No, we don't have enough money. We don't have it. And if you ask the government, right now, the US pulled up about $400 million from the Kenya system. For the Kenya government to increase, that's about how much? 400 million multiplied by 130. That's a significant amount. If you look at the Kenya government to, it's more than 40 billion actually. The Kenya central government allocation to the Ministry of Health is about 130, 125 billion. So you're asking the government to increase that by 40, okay? Whereas 65 to 8% of our revenue is paying debt, okay? So the fiscal space, however much noise we make, is not going to expand. So we can't fill the gap. If you tell the Kenya, and even if you look at the budget of June, and I think it's, what I was saying, there is no increment for the replacement of the $400 million of the US money. And that's not only in Kenya, for governments in Zambia, in Malawi, and elsewhere. It's not possible to fill that gap. Okay? So, who is going to fill that gap in a immediate sense? It's you and I. It's out of pocket. Because the government can increase 120, and the 120, by the way, is not the total. The county is also allocated another 120. So, talk between national and county governments about 250 billion Kenya shillings. You want them to increase that to 300? They will not. So, who will increase? It's out of pocket. The person who was getting HIV medication from PEPFAR, if they are not available and they still have the HIV, what are they going to do? The family now will come in. So what will go up the out-of-pocket expenditure? So in the medium term and the long term, the only thing we need to do is to reduce our health expenditure demand. Let me give an example quickly and hand over to Oronje. If you look at cancer, cervical cancer, it's a big burden in this country. You talked about it just now. It's a big, big burden. I was the chair of the National Cancer Institute, and for a long time we knew that for you to treat a cancer patient, it's more than $1 million Kenyan shillings, because they all come at level 3 and 4. So you need surgery, you need chemo, you need all that. But you know, Kenya has the opportunity, through Gavi, to vaccinate every girl before 15 years and eliminate cervical cancer in Kenya. But how much of government policy are you hearing going towards school-based programs to vaccinate every girl at 15? But the money, the vaccines are there, we don't have to buy them. They're actually in the store. Akwale has been in vaccination for a long time. They're in the store. Number two, if you look at, I'll give you just 3 examples. If you look at food, the biggest challenge this country is going to have in the already right now is non-communicable diseases. 50% of our hospital admissions contributing to the 600 billion of Kenya's health expenditure is actually non-communicable diseases. 37% of our deaths are non-communicable diseases. But where are they coming from? Food and lifestyle. So the first thing, let me talk about food. WHO has defined how much trans fats, industrial trans fats, should be in every quantity of food, 100 grams of food or whatever it is. There is a policy framework that's supposed to control and say, if you're selling KFC or you're selling burgers, this is the only amount of industrial trans fats allowed. Has Kenya ever implemented the WHO recommendation policy to ensure the food we are selling to our people, and people are queuing with their children to buy KFC, to buy burger, to buy all these foods. Has there been a food policy recommendation in African countries to ensure that the people selling industrial trans fats actually implement the WHO recommendation? No, only 2 countries in Africa have implemented, South Africa and Nigeria. So that's nothing to do with donor money. And if you do that, you reduce the chance of people getting childhood obesity, diabetes, hypertension. It is in our hands. The final one I'll talk about, I've just seen a paper in the Lancet this morning, that walking 7,000 steps a day can reduce your risk of death by 50%. Only 7,000 steps a day. It's in the Lancet today. And if you increase to 8,000, 9,000, the risk of death reduces. And that's across, mental health, it's across diabetes, it's across other cardiovascular diseases. It is recorded, just 7,000 a day. But how many people in urban centers can afford to walk 7,000 a day because you're fearing your phone is going to be stolen? So you take the bus, you take the matatu, isn't it? So the government investing in security and street lighting to ensure that people who come from Nairobi in the evening can walk to Moja. Just making sure that you enable people to walk can cut the rate of admissions significantly. Does that have anything to do with the donors? So I think we should stop focusing on filling the donor gap and focus on creating and producing health by investing in the areas that are going to help our people to be healthy.
Okay, thank you. I'm already taking an audit of my own lifestyle. Let me come to you, Dr. Rosolonje. There's the initiative that your organization has been running, the Advanced Domestic Health Financing. And I just wanted you to share your reflections on that initiative and where you see opportunities maybe that are scalable.
Thank you very much. So the domestic financing initiative has focused on supporting governments. Kenya is one of them. There's Zambia, there's Malawi, and there's Uganda, to invest better, but importantly spend better. So we started off, of course, by looking at what heads of state have committed to put more money in health and also enhance how we're spending that money. But of course, we then pivoted to spending better. And that is where my conversion for the first time I thought was coming from. We are not spending better. Even the 7% you talked about we are putting in, we are not spending it well. Much of it, as our analysis have shown, nearly 40% of that goes to wastages, corruption, and leakages. So part of what we've been doing is support governments to spend better. We've done some work in Kenya with various counties, 5 counties, that have been very keen to understand how do they tackle their inefficiencies, the sources of the inefficiencies, And some of those analyses, the counties actually asked us to do it. So we didn't go there to say, you're spending your money badly, you need to do this. They said, can you tell us how we can enhance and tackle the wastages? But of course, those findings always come back to political will. We have wonderful reports, we are discussing the recommendations of what the counties need to do. The question is always, will they do it? Will they address the issues of absenteeism, of ghost workers, of paying all these people who they're not in the hospital providing services, but you're paying them? Are they going to address it? Because those are some of the sources of inefficiencies. There's of course the issue of lack of pooling in procurements. There's the issue of lack of strategic purchasing. So all those remain challenges that counties and even the national government, they need to address for them to improve the way we are spending the little funds we have. But just agreeing that if we, like the Tari said, you're not going to get the money to increase. But we are going to solve this by spending better. And spending better is, of course, what the Tari now do things earlier, like prevention, focus on prevention, and don't maybe go work. Then we
media houses, we've reported countless times that we have drugs getting bad, expiring, without them getting to the people. And my second question is about communication. The government is doing a lot, government hospitals are doing a lot, but the populace, the people, don't seem to have this information. A case in point was at Makadara Hospital. And I just went there to have some forms signed. And then during my chat with one of the nurses, they told me that if you come here, I think you just pay 20 shillings. And then
market, or rather they wanted an assured market. About 20 or so decades later, rather 2 decades later, we now have a gap, especially when we look at malaria vaccines. We're still depending on donors. How then can we implement local manufacturing, since there is a market and there is a need for it? Thank you.
Okay, I think we can take those three first. We'll start with the first one, the one on impact for communication and ensuring that information gets to the populations that need it most. How can this be done effectively?
There are two issues you raise. You raise the issue of communication and drugs. And the first thing is that we say that communication is understanding, meaning that what the communities understand is what communication is. And I think when you look at the source of communication for the communities, it is word of mouth, it is the religious leaders, it is the communities, it's their neighbors, it's where they go to the local, it's where they hang out. And that's why I think it's when you talk about the value of community health workers and community extension workers. Today, if you go to a village that is interested in agriculture, you'll hear that most of the information comes from agricultural extension workers, not from national government. It is what the local person who does very good tomatoes tells them. That's how to do good tomatoes. So I think the value is in creating what we want the people to know down where they live, and that's the value of community health extension workers, which has not been properly funded, because somewhere when we are doing the structural adjustment programs, the World Bank and IMF told government that invest in infrastructure, don't invest in people. And that's how agricultural extension workers, community health workers programs died. Now the government is trying to reawaken those. But that should be the source of information in a people-centered way, including the market where the people are on a daily basis. The issue of drugs can be a bit complicated and expiring because it's a mismatch. And Wale has been in the ministry for some time. There's a big mismatch between what is purchased
level governance structures at the ward, at those communities, that the levels of governance that community members engage with. Sometimes I've joked that as people who live in the city center here, I've joked that as people, I live here in Westlands, and do I know my ward leaders? Do I know their budgets? Do I know, do we engage those governance systems? You've talked about people not knowing that Makadara you can get some service at 20 shillings. But even us as individuals, we're not engaged, right? We're not holding our leaders to account. We know our taxes are going there to support all these governance structures, from the community level to the national. But are we engaging? Sometimes I've asked people with your ward level budget and what it's doing. People don't know. So we also have a role to play in looking out for that. I think I'll respond to the issue of investing better and spending better. Investing better, of course, it's very much linked to spending. And I'll give an example. I was once on a panel like this with some very senior government officials. I won't mention which country, but there was a very senior government official from one of the countries in the region here. Once in such community and feeling very bad because the government arrived in big cars, right? Big cars from the city, you spend a lot of money, and it's not just one car, it's several cars, and the guy was saying he was sitting there wondering, if we didn't come here and just send this money to this community, systems, sectors beyond health. You see that often we're investing in the areas where we're not getting the most out of those investments. So smart spending is not waiting for people to be very sick and they go to KEG and spend there. There we're just supervising death. Smart spending is us focusing on having people years, and these are Homa Bay, Taita Taveta, Nyandarua, Laikipia, and Tana River. And mostly these counties have, much of what we've supported is really technical assistance. We can have side conversations around what's coming out of that. I think that was all. The next question for Dr. Pale.
Yeah. Oh, this one. Okay. No. Yeah, thank you very much for this conversation. I've picked maybe 3 areas to touch. And one is the issue of communication and data. The donor is meeting the objectives or not. And the country, they had vertical system, like for example in TB program, where they needed data to know who has been treated, who has received this, who has So I asked myself, do we even know how many people now have missed their TB medication? How many are going to develop multi-drug resistance TB? So data information system is extremely crucial. And that again tails into the issue of expiries. Is our system giving us the actual need of what we want? Efficient, but with innovation it needs to be on top. But then we must address the bigger elephant in the room. Who decides what is procured? Mid-2000, one time we woke up to find that the ministry had bought some the medicines for mental illnesses that would have taken us 10 years. That became the priority. I'm saying that because it's now not current news, but during that discussion, really, who made that decision? It was a very hot discussion where I sat. But that has been compounded by also now devolution. Counties may not be paying KEMSA, but they are procuring. What are they procuring? You always hear counties haven't paid KEMSA, isn't it? But do you also follow up to find, are they also procuring, and what did they procure? And was there collaboration before they made that decision? Now coming to Helen Shikanda's question about assured market. The market is there, but how do you ensure the local investment will actually serve that market in what you call efficient, cost-effective, and sustain the business? The truth of the matter, when you come to the vaccine space, the biggest global manufacturer is the Serum Institute in India. If you start producing vaccines here and you try to match their standard, they will be so costly that you the producer, may not even sell them anywhere. The same vaccine coming from Serum Institute targeting your market may be half the price or even more, much lower. And that is why, if we have to support that, one of the things is strategic partnerships. If Serum Institute came to Kenya and said, we are making this the base and we want an assured market to cover East, Central, and Southern Africa, then it becomes a viable option. Otherwise, then you are competing people who started growing before you were born much, much longer. Thank you.
Any other question before we, okay.
Thank you. I just want to ask the experts in the room, seeing that this is media and editors, what do you think the media can do? Is it better, differently, to be able to report in a way that is progressive and not retrogressive? Taking, for example, what Dr. you've elaborated on, this is Kenya's expenditure in health or the need for health in the year. When the budget is read, we just read top line and we leave it there. So is there something that you would want, or that this group of media, because media is powerful at the end of the day, can do to report better, give solutions and advance, in addition to just highlighting the gaps that are there in everything that we're doing? How else can media advance that conversation in a way that develops? Because at the end of the day, we don't have any other country to go to. So how can media utilize all of this to make sure that the conversations are progressive, solutions-oriented, and move us and move the needle somewhere better? Thank you.
There was someone else with a question there.
Good morning. My name is Martin. I work at KBC. My question is to Dr. Kwale. Now that we're talking about health financing, you are reflecting at your work some times back, and you said during your time you never reflected on sustainability. And you said when money was flowing, you did not do a lot, and that you could do better. Why did you not do a lot during that time? And with the ODA cuts, do you think we can do better in that circumstance? Thank you.
Thank you very much to our panelists. I'm Daisy Voyanzi. I'm from the East African Philanthropy Network. And I'm just trying to think and unpack. Has Africa, or rather Kenya, ever tried to tap into unlocking domestic resources, let's say from the private sector, or from high net worth individuals, for instance, to support health and development in this space? Because we've seen reports in terms of philanthropy where we see Africa is when it comes to philanthropy, Africans give a lot. 138,000 billionaires reside and are in Africa. Have there been any efforts to try to tap into these resources and support our own initiatives?
The first question, Eric, would you like to take the first question on communications and progressive reporting?
Yeah. Yes, I can, thank you. But before I go to that, I think what Daisy has asked about the role of philanthropy itself. I do believe there is one model, and Dr. Githinji has mentioned it. We in Kenya are the proud developers of the first ever sexual reproductive health development impact bond. It brings together government, of course the Ministry of Health, UNFPA, UNSDG, Kenya Forum, Chigarize, which is a social enterprise that is like a tech platform, and the funder for this is Children Investment Fund Foundation. But also for the stage after the first years of how it ran and demonstrated impact, which has now become a global case study, a lot more local philanthropy are being attracted to it. So I think there is a case study there to look at and see how it can go. But then the question to the first question on what Dr. Masi is asking about, how can we probably report better? I worked at media as well many years back. I shall not mention the years, but I know out there died before at the turn of the millennium, where at the Nation Media Center as reporters, and one of the things I've learned in the journey is that the message is always with the recipient. And so if we are seeking to streamline our efforts in communication in order to not just show doom and gloom, but also not sanitize it to show that it's just a hopeful situation, I always think that there are three voices that every story must capture. The first voice is the voice of lived experience, and in whichever reporting, whichever news item, the voice of lived experience must be at the very center. The person, the community, the hospital, the clinic, the patient, the health worker, the lived experience. But that has to be triangulated with the voice of expertise. And in this room there is a lot of experts, but also the voice of experts is constantly, it's a turn away, you know. In the same hospital where there is a patient with the voice of lived experience, there is a technical person, either a doctor, a nurse, whoever. Their voice too counts because there is a perspective that is not complete if that voice is not there. But then to make it wholesome, we've got to also add the voice of influence. And that's either the voice of the funders, the voice of government who shape policy, the voice of the ones who will eventually determine, especially resource flow. So a balanced story, especially in matters health, in my view, is only balanced if it has those three voices together.
I can quickly touch Mania. Yeah, okay, let me take advantage of this. I was asked two questions in terms of domestic resource mobilization. Yes, the Malaria Council, private sector, we have gone into that. We've been talking to philanthropists, private sector in particular, both retail, private sector, and manufacturers. Some good responses, but always the question is, once we've raised this money, how is also but it will help your programs. But you know, in businesses, we must also do business. How all this, and the aim should be to reduce out-of-pocket expenditure. But where should this money be coming from? So during those days, because the money was there globally, you write a proposal, the money comes, you say we are able to reach this, and then at that time when you go to Treasury, actually, we used to be told, but you people have donor money, why are you asking? I recall a year when we wanted more money to vaccinate children. We had been given a 5% increase, but we argued, last year we vaccinated 1 million, next year it is 1.2 million. Now if you give us 5%, we will not cover the 1.2 million. So the question was, we asked Treasury at that time, tell us, which child shall we leave to vaccinate? Give us a formula. They could not, of course, answer, but they told us, you got part of the reason that we are where we are. So it's not only a small group, it's not me and my team. It must be looked that financing is across government, and therefore the government must work as one when it has to make decisions to deal with funding. Thank you.
I could comment on the philanthropy, the African philanthropy issue. It says that the global giving report, what we call the global charity report, Kenya is right up there in terms of giving, but they give in kindness to a neighbor and volunteerism, not in cash. The countries that are top in cash are Europe and North America, maybe Myanmar, and most of that giving is to the church, a lot of it, and some of it, of course, to the things we are talking about. But there's a huge philanthropy source of money from those countries. Or health financing coming from out of pocket. Who funds out of pocket, actually? It is you and I. I don't know how many people have done Harambee in the last 1 week to fund some activity for health. I have contributed, and many of us have contributed. We don't count that as philanthropy. It is actually philanthropy. When we get these diaspora remittances that the government is always celebrating, how much of diaspora remittances actually come to fund health for relatives here? The last estimate I saw is 30%. 30%. But where does it come to? It comes into out-of-pocket expenditure. So the amount of money we are talking about of out-of-pocket, which out of the 650 billion is probably 200 billion, is actually philanthropy by families. But when you now talk about large philanthropy, what we call high net worth individuals, giving 1 billion shillings to a hospital or something, we don't see much of that in Africa. And the reason for that is twofold. One is the structure of the money. If you look at Bill Gates, and he's the one who funded some of this work, the philanthropy in America is led by the stock exchange. It's not money in the bank. It is a stock exchange. So if I own Microsoft, or I own something else, and I have a stock option, maybe my stocks on that are 30% or 50%, I then allocate a part of my stocks to my philanthropy. That is why the money keeps growing, the stock exchange is moving, and that's why a lot of the big philanthropies are in the US, because the US has the largest stock exchange. You don't see many large philanthropies in Europe. You don't, because the stock exchange is much smaller. Now, how many of our billionaires are stock exchange billionaires? Very few. And actually, if you look at the structure of money in Africa, it is largely in real estate. Unless you go sell your 100 acres to give to charity, you don't have any stock to allocate to philanthropy. So this is a study that has been done, and therefore, however much you try, you're not going to mobilize 100 billion Kenya shillings from philanthropy to put into healthcare. You won't. But you will find individuals who are giving $20, $30, $50 to support their families, to support out-of-pocket expenditure. That's the issue of philanthropy. The other role is the issue is of role of private sector. I just wanted to comment and say that the private sector already contributes in taxes. Most of the taxes actually, the biggest taxpayers are private sector. And that is what the government then uses to support the budget and allocation to health. So the private sector supports significantly. What we then ask ourselves is, what is the role of the private sector in supporting social services directly? And I think that's a debate in boardrooms about social health investments, or even what we call corporate social investments. But the private sector is already contributing directly to taxes. But what we want them to contribute is through philanthropy, and that's a bit more difficult because they have to then declare profits, then take part of their profits and give it to them, and then their shareholders will say, no, give the money to us, because we're also under pressure. But the biggest role of private sector, I would think, would be partnering with government to create healthy environments. Healthy environments, making sure that, for example, there are walkways that people can walk, there is street lighting that people can walk at night without being afraid, there is actually proper lifestyle programs within the companies. I think that's where they would actually contribute significantly, rather than giving actual cash, because the actual cash is going to be constrained significantly by the demands within where they're playing. Remember that primary healthcare is multi-sectoral. Primary healthcare is primary care, what we're talking about here is community empowerment, we've discussed a lot. The thing we haven't discussed is actually multi-sectoral approaches. Food, water, sanitation. And I think the question that was asked about domestic resources, my question is always, what are we counting? If you say massive state expenditure is 600 billion or 500 billion, and out of that, how do we count? We count what the government allocates to health, what the county allocates to health, that's about 50 billion. But what about the amount of money in water? What about the amount of money in sanitation? What about the amount of money in nutrition? Is that health money? That is health money. Actually, the media starts to look at, we need to stop looking at health allocation as just what goes to the Ministry of Health. The money that goes to education of women, the money that goes to sanitation, water and nutrition is health money, because an educated woman, her children, the children of an educated woman have a 50% less chance of death before 5 years, just by educating the woman. That has nothing to do with health, money allocated to the Ministry of Health. Yes.
And there's also the role of media that Marcia.
Yes, I wanted you to talk about this. So I would say two things. I keep reminded that the media does not tell people what to think, it tells them what to think about. So I think you have a big role in shaping the narrative around health expenditure. So that we are not just looking at health expenditure as Kenyatta Hospital and all that. And I think, and you do that by sustaining the coverage. So it's not just coverage around when budgets are released, but it's also, actually that is not, often to me that's not very important. What's important is how the budgets are spent. Because sometimes we celebrate, we now have 10% increase in this budget, and then when you look at how it's spent, you realize that it actually didn't give you any returns. So how do we sustain, what media channels do we establish to sustain coverage around how is money being spent and what are we getting out of that? Because that is what will change lives. So that we are keeping our governments and of course even Wananchi on top of understanding how is money being spent towards health. What are we spending it on? And also importantly, what's coming out of that? Are we spending our money in the right place? We don't do that by one story, we do that by sustained conversations. And then of course media needs to address, also shape the narrative around, there is no crisis in Africa around ODA cuts. The crisis is what has been there for a very long time on how we are spending money in wastages, leakages and corruption. That is not new, that has been on for years and it's still on right now. Nearly 40% of the monies we put in health is wasted or leaked or stolen or something. That is a crisis that the media needs to focus on, because ODA cuts, as Dr. said and Dr. Wale also said, ODA is a big contribution, but it's not what will change our health. What will change our health is our own money that we are putting in, but also how we are spending that money and what we are getting out of it. I think we need to change that narrative, because it almost looks like Africa is struggling because there are ODA cuts. That is not the challenge. That shouldn't even be the narrative. The narrative is how do we change our story to spend better, but also to look at health holistically and looking at health as a multi-sectoral issue, as Dr. has said. Media has a role in changing those public discourses and changing public narratives, and also letting people know that we can take charge of our own health, like you're talking about diets, vegetables and all that. I've seen people take charge of their own health by just changing their diets. They don't have to spend so much money on diabetic medicines and those insulin anymore. So we also have a role to play. So the media can change all those through its watchdog role, information role, and of course just shaping public discourse. Thanks.
Okay, I have another question here from Francis Openda, the KEG Vice President. And he says the new bill by Sabina Chege compelling public servants to use public hospitals. Is this feasible? Is it feasible, do you think?
How many of us seated here use public hospitals? Who has used a public hospital most recently? And this is an honest question. Yeah? If you used a public hospital within this year, raise up your hand. I thought you told us you were in a hospital there. Makadara.
It's a while, not most recently.
Oh, not recently. Yeah. So it's not about the question of the politicians and civil servants. It's about the question of perception of quality. Yeah. What I've seen is that I chair the board of Bagavi Hospital, by the way. And I do that because I want to understand what's going on in the public health system. So I'm the chair of the board of management. And 99.9% of our patients are the informal sector, actually. But we have people around Gumo area and other places that say, if you improve the waiting area, the waiting time, how come? Because people don't want to come and queue, because the service delivery, it's actually about customer service. It's not about the quality of services. Because I can tell you that if you are looking for a neurosurgeon, the one in Kenyatta is actually better than the one you find elsewhere. If you're looking for an oncologist, the one in KUTRH is better than the one you find in the private sector. So we in the public sector have the best specialists. Is it true, Dr. Twale? The best specialists are there. So why is it that an MP would prefer to go to another hospital, yet the government has employed the best? And that's where the best are in those hospitals, because that's where the highest volume is. Because clinical practice is also about dexterity, acumen, and experience. So if you're looking at doing, for example, a procedure on the heart, how many people in Kenya require procedures on the heart? They are most likely to be Kenyatta. Therefore, if you want to be better at open heart surgery, you'll actually probably get it better at Kenyatta than MP Shah or elsewhere, because that's where you have the volume. So the quality is not the question. The question is customer service. What we found, I went to visit Lamu Hospital recently. And when I went there, I found what they have done is they have created these our services, but they have created a private insurance and civil service customer service unit. Okay? So you come in, but you don't go to the general queue. You go to an area where you sit, you have sofa sets, you know, you have nice, there's coffee, there's tea. And when you sit there, you are attended to, there is a private pharmacy in there, there is a lab, but the lab doesn't, the best lab is in the hospital. So what you do, they have a phlebotomy section there. So they take your blood from there. Where the results come from, we don't care. So you go to the public lab, and then you get your results in the comfort of this lounge. So I think the question is not to force them. And I don't think anybody can force anybody to go to a particular hospital. It's to ask from a human-centered design, what is it we need to do to increase the flow of private people and our leaders to the public hospital where the best quality services are. I think that should be approached. Rather than let's force them, it should be let us actually improve that. And maybe by forcing them, they'll be forced to improve the customer service, probably. Yeah.
Your last word in 30 seconds before we wind up. You're winding down.
Oh, you're winding down.
Yes. This session.
Yes. Let us focus, as I say, on the 80% of the money that comes from our taxes and our pockets. That's out of pocket. Let us not be so distracted by the 20% that our partners givers, because aid is not charity. Aid is not charity. And there's nobody who gives us money without strings attached. Nobody. When you look at Gavi, they're donating money, but in the background, there's private sector that is actually selling the vaccine. That's the market that I'm talking about. And even when we've attempted to make Gavi to buy a lot of vaccines, they are beholden to the private sector that provides the ones they buy. And those people sit in their boat. Okay? When you look at the US and their money, where do you think the money is focused on HIV, TB, malaria, and Ebola? Why? Why is the money not in cervical cancer, hypertension, and diabetes? It is because the money is to protect Americans from getting diseases from abroad. It is called global health security. So when you say give us money for cancer, they say, but you can't give us cancer, so keep your cancer. You can't give us hypertension, so keep your hypertension. Only 2% of the ODA money goes to non-communicable diseases. 2%. The majority of it is for diseases they want to make sure they suppress so they don't get. So there's no aid that is charity. So let us focus on our government and ask, why is it that the government has not implemented better food policies so that we stop our people from getting childhood obesity? Why is it that products that are sold from Italy and elsewhere have regulations about advertising to children, but when they come here they are advertised freely? They are put on the counter. Ask those questions, because then you are protecting the health of the people for the future. So let's also focus on health production, not just consumption.
Totally agree. And just to say that let's, as media, let's play the role of changing level, but also the public sector and the government level. We can play a big role in enabling government and individuals to see that health is bigger than the facility, and that if we focus on the individual and the community, we'll have better health outcomes and reduce all these high expenditures and deaths.
Said this session was standing between you and your tea. Now we can take a break and then come back to the next session, which is our last.
Unaweza nikopi ile kupitia tribe nikopi ile session hii ama nikupatie mahali nitumie hiyo link. Unajua nimekuwa live bado kwa live kama tunataka updates ama hiyo session hii video ya kwenda TV quality si nzuri.
The bigger ones. Okay.
Thank you.
Thank you. All right.
Are you sure it's not picking it up? Sababu nimeweka hiyo ni mic karibu na screen. Should have had better sound. Are you sure your source is nikitoa mbaya? Nikitoa hivi iko very bad. What I think is happening when you capture hiyo na capture you are familiar. I think here with your camera, easy fit the camera. No, but you can decide which. Okay, so when the sound comes here, now you can produce a certain unit. How it comes? It's easy. Just have quietness. So this which is that? Kama zikabidi but nimekuwa zote hiyo tu. Side quiet. Not loud. I think naona pia nimekambia Mic check, 1, 2. 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 Mic check. Unasikia? Hiyo ni na test mic. Na test mic nimeweka nini? Unasikia nikipik? Mic check. Ina pick. Huh? So this guy is
behind that. There are people benefiting from us procuring the wrong things. That comes out of the need for leadership, political will, and us being very honest that to change the story of Africa as far as the health burden is concerned, because we know that Africa accounts for most health burden in the world, we need to do the right thing. We are where we are because personally I feel we haven't been doing the right thing for a very long time. So it's clear that when we look at our expenditure on health, in some countries, we are depending on external aid by 40% or more. That means we are overly dependent on external aid. And that shouldn't be the case because we have the resources locally. And when I say we have the resources, I don't mean that we have money to fill the gaps the funders have left. But that if we change how we spend on health, then we have the money because we'll spend less. So if we focus at the community level, we focus on changing what we are spending on in health in terms of people improving their lifestyles, people improving what they eat, us doing screenings at community level so that some of the terminal diseases can be picked up much, much earlier where they can actually be managed and prevented. It means that we'll spend less eventually in health, but we'll also save a lot more lives and reduce the burden of death that is currently the continent is holding. And so it's really us not looking so much at how much we put in, but changing how we look at health as a paradigm, looking at health as a community level issue, health as an issue that is beyond the hospital, health as an issue that communities need to own through the various sectors, agriculture in terms of nutrition, education in terms of enabling communities to live better lifestyles, eat better, but also water, ensuring that we have the right clean water systems flowing in our houses to improve healthcare. Very much. I hope that made sense.
Yeah, it does. Thank you so much.
Thank you, guys. Yang mama. Okay.
Just like you talk about 80 and the 20% we will replace this. So why as a country we need to focus on financing ready on the donors and there is no collaboration in the country, so the donors have decided to donate the 20.
Yeah, absolutely.
Thanks to the Editors Guild for this, and I think the conversation here that we are having is about health financing. And if you look at health financing in Kenya specifically, and many African countries, many of them, you'll find that 80%, 8 out of every $10 is from the country, is not from the donors. Only about 2 out of 10 is from the donors, only about 20%. If you look at Kenya specifically, Kenya spends about $5 billion on health. Out of that $5 billion, only about $1 billion is from donors, from all these global fund, Global Vaccine Alliance, US government and others. $4 billion is a contribution of the taxes of the people and the people from their pockets, what we call out-of-pocket expenditure. It is people who have a patient in the hospital and then they have to actually fundraise or sell their land or something. That comes to maybe about $1.5 billion. And the balance of it is the county and national government. So 80% is from us. So when you have withdrawal of development assistance, the question is not about that there is no more financing. It is that there were certain programs that these donors were funding, which was vertical. And the majority of that money, which is $1 billion, which is where the change is happening, out of the $5 billion, is that they were funding specific programs that are of interest to the donors. That's HIV, tuberculosis, malaria, a bit of maternal health. And it is not to say that this money was not beneficial to the Kenyan people. It was, in fact. Most of the HIV medications for the people, about 1.3 million people, who are people living with HIV in Kenya, their medication on a monthly basis is funded through this money that is being taken away. So it is, of course, a big impact. The question is, how does the government reorganize the $4 billion to ensure that it accurately takes care of the most vulnerable who are being left behind by withdrawal of this money? So it's not a collapse of the health system. It's a question about how we reorganize our existing money, reduce what people are paying out of pocket, increase the cover for the most vulnerable, and make sure that there is social protection so that those people who are receiving these medicines that have been pulled away continue to receive, and reorganize the efficiency of the money that actually the government and the people have through better efficiency. That is really the big question that we need to ask ourselves, because it is not charity. It will go. The question is, what is our role in financing health for our own people, which we are already doing.
What are some of the projects, in your opinion, you think that have been affected by the decision by the donors to aid? And if we take the map on our own, the country can do better. Some of the critical services or projects that are
the most critical services that are funded by donors but are now facing the risk because of the withdrawal are medications for people living with HIV. That's really critical, because Kenya has about 1.4 million people living with HIV. They need medication for them to be fully participatory in the economy. And that is one thing that the government must do, to ensure that these 1.4 million people who are receiving HIV medication from donors are in the budget and continue to receive their medication. That's number one. Number two is tuberculosis. The people who are being treated and tracked to ensure that we reduce the burden of TB, the government must continue to do so. The next one is family planning. There was a lot of family planning support by donors, yet our government and many governments in Africa have kind of left family planning, commodities and care to donors, because it's not seen as a critical area of investment. Yet, we know that if we don't actually invest in family planning, then our fertility rate goes high, our adolescents continue to be pregnant. In this country, 25% of girls between 15 to 19 years are pregnant or have been pregnant before or have a child, which is a big challenge to the economic development because they can't go to school. So we must refocus and say these programs which are critical for socio-economic development, the government must budget for them or reallocate money to ensure continuity.
I would also like you to talk about the fact that you think public health facilities in the country have some of the best services, and we only need to improve, the others the customer service, so that people can benefit from the services. Most people do not know that the services are available here because of stereotypes. But you as a doctor can confirm that services are available. what do we need to ensure that more people embrace health facilities?
Yeah. So there is a question here then around how we finance our health services across the country. So I would comment on certain things. Number one is that public health financing and public health services are the most critical in ensuring that a country has a healthy population. Focusing on public health provision. Private sector is extremely important, but must be a partner of public health services, not an alternative to public health. Meaning that the public health services should complement where government needs help and should complement delivery of publicly led health services. That means that public facilities should be at the backbone of health service delivery. We know, for example, in this country that the best services in terms of quality actually exist in the public health system. But people believe that the best services are private sector. If you look at quality assurance, the best quality assurance programs, largely, this is not copy and paste to every facility, but the best quality assurance is actually in public facilities. That's where you find the best cardiologists, that's where you find the best laboratories, that's where you find the best surgeons. And the challenge that we've had is the areas around customer service, compassionate care, overload of the health workforce, continuity and follow-up, patient navigation. And I think this is where the government needs to work on, so that the public can willingly start to shift to sourcing their services from public facilities, because that's actually where the best oversight and the best care is. But we are lacking the side of compassionate care and customer service, which is what needs to be worked on, so that even as we talk about forcing civil servants to use public facilities, it is about asking, what is it we are going to do in the public facilities for us to encourage people from private sector, including our civil servants, to actually use public facilities. And that is possible. So there's no need of having a program for civil service, a program for others. All Kenyans are equal, and what we need to ask is, what is it we need to do to our public services so that every Kenyan feels comfortable to seek their services from there, and the private sector becomes complementary and supplementary to the publicly led health system. Thank you very much. Yeah. The question around whether our healthcare services are aligned and whether our public expenditure is adequate is a question that is related to whether we should focus on health or whether we should focus on healthcare. There's a difference of night and day. When you focus on health, it means that you recognize that every individual is born healthy. Only about 5% of people are born unhealthy. 95% of people are born healthy. Therefore, focusing on health means that you want to keep the people healthy. Focusing on healthcare means that you want to focus on waiting for when people get sick and treat them. And we cannot afford that kind of approach. That is what we call the biomedical approach to health services. Now, in this country, we cannot afford a healthcare model. And in many African countries, not only in Kenya, you cannot afford a healthcare model, largely because our economies are small relative to our population. I'll give you a key number. Germany, as a country, has a population of 87 million people. Its GDP is $4 trillion. Africa, as a continent, has a population of 1.4 billion people. Its GDP is half that of Germany at $2 trillion. So if you just look at those numbers and population, even if you taxed well, you will not have enough money to take care of healthcare needs of the people the way Germany does. Because with 4 trillion for 87 million people, you can never afford the same with 1.4 billion people with half that GDP. That means that we have to disabuse ourselves of the fact that we can actually send money or pour money at the problem. We have to start thinking about producing health production. Starting to think that our budget for health have to include how many people have clean water, how many people have adequate sanitation, and how many people have nutrition, because that's where diseases come from. Number 3 is about then asking ourselves, what regulations and policies do we need to pass through our parliament to ensure that people are having healthy foods, not just by their choice, but by protecting them, because they will not always know what is healthy and what is not. What is the role of food labeling to say this food is unhealthy?
We did that with cigarettes. We've done it with alcohol. Why can't we do it with sugar? Why can't we do it with other fast food that people are consuming? So that you make a choice to buy your child a certain food. You know you're making an unhealthy choice. But now without labeling, without front or back labeling, you'll never know. And that's why we are having rising diseases of what we call non-communicable. Hypertension, diabetes, obesity. 50% of all our admissions have to do with these diseases. Not HIV, not TB, not malaria. They have to do with cancer, diabetes, and hypertension, which we can prevent through regulation of food and also enabling people to live healthy lives by having security on the path that people can walk at night instead of having to take matatus to go home. If we provide security and street lighting, people can walk. And as I said, if you walk 7,000 steps a day, you reduce your risk of death by 50%. Let us focus on producing health, not treating disease.
Thank you.
Thank you. You see, on one side, I'm saying that let us focus on building health, but we will have people who need medications. That's inevitable in every community. But then you must have data. That data must lead you to decide, in this particular community, the medication that we are likely to need are for malaria, because you're in a malaria endemic area. But in this other community, the medication you need is for hypertension, because these people are more likely to have hypertension. That decision and that data is what will make you decide what to buy and what to stop. Community by community, it's precision public health. You must decide based on the community and their disease patterns what to purchase. But if you have centralized, supply-driven purchases, not demand-driven, then you end up with a mismatch, whereas what you procure may not be what is needed for the particular population. And that then means that you may procure what's not needed, and because drugs are expiring, they're going to expire. And the ones that you needed, because you didn't use data, may run out because the demand for them is higher than what you purchased because of a mismatch between supply and demand. That's what we need to do.
Okay, thank you.
Thank you. Sorry? What did I tell you, French? Kado. Kado. Ndio waendelee na ingine. Sawa. Okay.
Thank you.
Thank you.
You have got everything there. Two questions.
Huyo ako wapi da? Hi.
You know we have a session. Excuse me.
Okay.
We have a session, so I hope we don't take.
Just a summary of what you said here about the reduction of and how it's affecting the system in the country. On your thoughts on that?
Yeah, thank you. I know recently there's been a big concern about the reduction in donor funding to the health sector in Kenya and across the African continent. I need to say that actually the reduction in donor funding began a while ago, and it has only been made worse by the reduced funding, especially from the US government towards health. And as you know, a lot of the funding, global funding to health, targeted especially certain programs, HIV, TB, malaria, and the vaccination programs. And these are the ones that have been impacted with this reduction. And when the money was available, especially from mid-2000s until early this year, we saw a market reduction in number of cases of the major diseases in terms of deaths from the major diseases. But we also saw expansive programs, some of which one would then consider as very expensive to sustain. So in terms of this reduction, I personally look at them in terms of immediate, medium, and long term. Some of the immediate concerns, obviously, is the fact that there has been job losses. And some of the best brains in the health sector who are working within these programs are now on the streets. They are not contributing to the health sector as would be needed. They ran some of the best programs that Kenyans benefited from. Of course, there's been also the impact economically in terms of hospitality industry that hosted a number of activities, travel and all that. But then there's also one other immediate. Some of the data systems in the health sector depended on this funding. And data is so important to inform the next steps. You need data to know how much medicine has been utilized, how much you need to have in the pipeline. You need data to track patients. For example, TB patients, you need to track and know who is taking medication, who has defaulted, who is likely to develop multi-drug resistance tuberculosis. Without that data, definitely we are then walking and groping in the dark. And it's just then a matter of time to start seeing an increase in the number of cases, malaria cases, for example, TB cases, HIV, maybe a return of mother-to-child transmission. And we therefore need to be wary that much as we are now talking about this reduction in what you call strategic and forums like this, but it is going to translate to deaths very soon. And therefore, I think what is important is we need a very honest and sober discussion to say, within our health financing infrastructure, how are we going to forestall that situation that is going to start coming maybe a year or two from now? That, to me, and to ensure that despite the cuts, with the limited resources that we are left with, how can we integrate programs and also target resources where there's maximum need?
Oh, pole.
Thank you.
That's why I was
to prompt you and also just help us think about what next for official development assistance. It's not just rhetoric anymore, it's an urgent conversation. The choices we make now as a country will shape the future of the development of not only our country but across Africa. And why I say it's no longer a rhetoric, that it's urgent, is based on the Trump administration. 20th January, he sworn in. 6 days later, stop work order. And Dr. Kwale had mentioned it here, that when you have plenty, you don't really think about that time when you don't have money. And that sustainability conversation, even as early as this year, is always a footnote that, you know, and it's usually almost predictable. To record, you know, around, I think now we are at 3 or 4% prevalence of HIV, around 1 million people on treatment for HIV. If you're looking at vaccination, for example, it has helped many, many mothers. Some of you are here to see your children's 5th birthdays, because otherwise, measles, whooping cough, you know, rotavirus would have eliminated them. And I remember when I started at the numbers and you narrow it down to the people who have benefited. And when we talk about reducing communicable diseases, it's as simple as mothers seeing their children grow healthy. But today, with what we have had early in the morning and what we know is happening globally, that ODA backbone is weakening. The US is increasingly, and as long as this administration is there, is increasingly looking inward. The UK, as recent as a few hours ago, has introduced and given a plan on how it's going to cut its aid budget. If you look at the Netherlands, the EU, they are increasingly shifting their priorities to be inward. So as a continent, as a country, we also need to look inward. Some organizations like the World Bank are warning that, you know, there'll be a sharp decline in this concessional financing over the next 5 years, 2 to 5 years or so. Gavi, the other day when they are doing the replenishment call, is struggling because it's underfunded. The US pulled out. The Global Fund, US is increasingly looking inward and was the biggest contributor to the WHO also. So as a continent, as a country, we have to look inward also and ask ourselves, what do we do to make sure that in these disruptions, that the financial pain is there, yes, but the disruption is minimal. In Kenya, the consequences, and they have been elaborated, they're very clear. There's reduced funding to community health services, there's disrupted supply chains on HIV, TB, malaria, commodities, and there's uncertainty around the vaccine procurement. The other day we were reporting about the vaccine shortages. So these disruptions are where we come in as media, and we need to speak about them. But like I said, we need to advance that conversation and just beyond saying ODA has reduced, these are the gaps, what next? Because the solutions are there. The cost of inaction for a country like ours is very steep. If the ODA continues declining without us looking at alternatives, we risk reversing many, many decades of progress. And I just look back at the last 25 years because that's when Gavi came in, so the issues of vaccination and childhood illnesses were addressed. 25 years ago, the issues of HIV and PEPFAR came in. So we risk reversing those progresses. We risk seeing maternal mortality, which has increasingly been dropping, rising again. Vaccine preventable diseases may return. And we've seen what has happened in the US with vaccine hesitancy and people not vaccinating their children against measles. You're seeing a country like US reporting deaths from measles. And we risk also starting to report that at an increasing levels. So these health systems that people have painstakingly built over the last many decades could falter. But more than the money, this current situation of aid freeze reveals a deeper problem. It reveals our over-reliance on external funding. And I like what Akwale just mentioned it here. That back then, when you go to the ministry to present your budget, like, we need this additional funding, then they're like, talk to your donors. What does that tell you? We have relied a lot on donor funding, but it's about time to think differently, to stop treating development assistance as a permanent solution, but rather we should treat it as a temporary bridge from one place to the other. So what next? And this is to you as members of the Fourth Estate. We need to clearly redefine the role of official development assistance from the lens that we see as media in reporting. It must evolve. Rather than reporting it as something that plugs the funding gaps, we should report it as something that strengthens the capacity for our African health systems. It's supposed to be catalytic, not a substitute for our health systems, for education, for our agriculture. So we need to change the narrative. We need to change our reporting from saying we have a funding gap, but look at it as it did this, but what else can we now do now that we are on the other side of the bridge to be catalytic and not a substitute for what should have been allocated or spent from our own internal budgets. Again, we need to move from aid to co-investment. What does that mean? We need to reframe official development assistance as seed funding to spark domestic innovation and investment. It's not something to perpetuate a lifeline of dependency, so that it's a core investment, something that is your capital investment for you to do something and move forward, but not something that we are depending on in perpetuity. We need to discuss and highlight domestic resource mobilization as a country. As African countries, as Kenya, we must step up. The health financing gaps targets, like was said at Abuja Declaration, the 15%, and Dr. Gidinji talked about it. We have to move away from that and start seeing, where the funding can come from domestically. We must increase tax efficiency. It's still part of domestic resource mobilization. What Dr. Oronje talked about, reduce leakages and wastages, and we must promote efficiency. With the money that we have, what are we doing about it? We must reprioritize health spending. And it has been touched here, and I hope you can be able to cover this, is what Dr. Githinji really elaborated, where these programs come and you're only covering malaria, you're covering HIV, you're covering TB, but not looking at the person as a whole. What that does is cause inefficiency in the health system. And we've seen that when they pulled out, then you find that you have a weak foundation. So we must report differently and offer solutions, because those things the solutions are there. The fiscal space is limited, but what are we doing with what is there? You go to, and I will challenge all of you to have a look at this. If you go to the Gavi website, they publish everything. So they did an audit report of Kenya and how Kenya was spending the Gavi funds that come into vaccination. And you'll find that expenditure is not supported. You have drivers that have been sent to pick vaccines, but there are no vaccines that have been picked, and then vehicles have been fueled, they've been given per diem. So you ask yourself, this is donor money that's supposed to go to vaccinating children so that we have zero-dose children, but there are people who are earning per diems, fueling without necessarily fueling, picking vaccines that are not there. So we have to look at those wastages, those leakages, and make sure that we bring them to the fore, because at the end of the day, our job is to hold power accountable. We have to look at the role of local manufacturing. Universal Corporation, just here in Kikuyu, less than 25 kilometers from where we are, is one of 2 pharmaceutical companies that have been pre-qualified by WHO in sub-Saharan Africa to provide medicines. The other day, they were allowed to provide ARVs. They have been providing, I think, family planning commodities. There's malaria, and it's just here. But what does our country do? We import the same medicines that are being produced here. And the challenges that Universal will tell you is that the manufacturing environment is not supportive to what they are doing. The labor costs are increasing. But are we asking our government what they're doing to support an organization like that is globally recognized to procure medicines and send to 19 countries in Africa? But here in our own country, we are not, yet they're just, 25 kilometers from the capital city. Are we asking those questions? Because if we are to use the resources that we have locally, then it goes a long way in bridging the gap that we've seen that has been left when the donors will pull out, and they'll continue pulling out. The fourth thing that we need to think about is new partnerships. From private sector, from local philanthropies, impact investors, all this must be brought to the table. There is untapped potential in public-private partnerships and blended finance models that come with that. So as Africa, we have these ideas, we've heard them this morning. We just need different partners to believe in them, and I dare say those partners are within this continent. We don't need to look beyond where we are. So what then is our role as media? We as journalists, editors, communicators, we have a profound role to play. We must document not only the pain of the withdrawal of the official development assistance, but the opportunities for African-led solutions. And I've given Universal as one of them, and there are many others. We must frame these public debates around equity, around accountability, and around innovation. We at Willow Health Media, we've seen the power of such kind of reporting, the power of powerful journalism. It can shape public policy and perception. When President Trump gave the executive order, we did a special coverage on the US government aid freeze, and you can have a look at it on our website. And we covered it as an evolving story, up to holding a webinar, because we needed to bring different voices into that conversation. We looked at, we called it a vanishing lifeline, can Kenya's healthcare system survive without US funding? And we looked at the US funding in Kenya since 1950, just to see what that gap would look like. We looked at the Ministry of Health. Out of the 80 billion shillings per year that comes into these funded programs, the US government funding is around 28 billion. So looking at those, our responsibility is to ask, the people, the policymakers, what it is that they are going to do to make sure that, yes, money has been withdrawn, but what are they doing to make sure that the services still continue and that there is no disruption in provision of medicines and the other commodities that people need. And we've seen in certain counties where they have flattened the verticalization of the programs that we've talked about to integrate them into everyday health system provision. And one of them is like Nakuru County, where when clinics were not working because of the funding crisis, they just integrated it into the usual public care or public health care. We looked at vaccine shortages and looking at the last 25 years. So we looked at how the delayed vaccination would have consequences on children, and I've talked about it, and how this is tied to our shrinking global and domestic commitments. We're looking at Kenya's commitment into funding its own vaccination, and Kenya should have taken off by 2030. But when you look at increasingly what we are putting into vaccination ourselves, it is not sufficient. So it's up to us to continue telling these stories, not giving up, and maintaining a sustained, let me call it campaign in quotes, to make sure that the policymakers know that we are on top of these stories and we are continuously looking at them. These stories for us have shown something very vital, that data informs, yes, but it's storytelling that mobilizes. It's storytelling that calls people into action. And we must continue to amplify what is at stake, and most importantly for us, what is possible. So this is a turning point for the country and for us who are in the fourth estate. Official development assistance, as we knew it, is no longer guaranteed, but that doesn't mean failure. For me, I see an opportunity. I see an opportunity for us to tell Africa's story from a solutions-oriented lens, holding governments and power to account, and not perpetuating what we call poverty porn, or the woye kind of reporting, so that we get help. I see an opportunity for us to take greater ownership in our storytelling, in the kind of role we play in the development of the country. I see an opportunity for us to reimagine health financing, and an opportunity for us as a media to lead, and not to follow, but to lead the path to resilient health systems. And that will only be done if we rethink and retell our stories differently, solutions-oriented. So for me, I just want to leave you with one thing, that we should not mourn the fading traditional aid as we know it as an opportunity. Let's embrace this moment, use it to look inward, and build something more sustainable, more equitable, and more African, because Africa is our business. Thank you.
I don't know whether this one is working, because I wanted us to have a discussion. If you have any questions for Dr. Mercy Korir, and I think I'll take the first question. If, for us here as journalists, if we were to report on the recent HIV drug, the twice a year, how can we report that? Pivoting from your reflections today, how can we report that and still be able to hold power to account and reimagine this model that you're talking about?
Difficult one. So when Lenacapavir was announced, Gilead was costing it at, was it $3 million Kenya shillings equivalent. And of course, when you think about that, I'm sure you'd be like, okay, let me just continue with the usual ARVs. For me, I would look at it as an opportunity. The biggest burden of HIV is in the African continent, South Africa being the leading. Is it possible with global partners, and this is a conversation that has happened even up at UNAIDS, for Africa to manufacture that medicine? Labor in Africa is way, way cheaper than if you compare with the West. Is it possible for us to manufacture it so that it's readily available? And with manufacturing, then it means there is long-term sustainability and a long-term assurance that the drug will be there. That's the first thing I would think about it from a sustainable point of view. The second bit is, of course, with every introduction of new medicine like that, from a business perspective, Gilead will be looking at recouping money, all the money they've spent many years of research and things like that. There's still philanthropic organizations and people who are willing to, bridge that gap. So could they bridge the gap so that that medicine is available in Africa? And what Dr. Gigi talked about is, at the end of the day, the West is looking at us, quote unquote, not transporting the disease there. So there are different ways to look at it, but at the end of the day is there a way to have this sustainably here? We're already manufacturing ARVs, so it wouldn't be something alien for us to manufacture that medicine there. That would be my thinking, but maybe Dr. Kwale has another view.
No, I like that thinking, but for me, it brings to question our actual policy development and implementation. I think we needed to ask a few more questions. Even as we adopt it, it is life-saving. However, what is the sustainability and what should we be looking for? Even if we say in the next 2 years, this is it, but we must be very clear we're putting in systems that will move towards local manufacturing. So whenever policymakers are making that forward-looking is very, very critical. The other thing is just to continue monitoring its impact and potential any other side events. And then doing more research. Might we come with even an equally effective medicine, but locally from our products? Yeah.
Thank you, Dr. Any other questions for?
And as we get a question, the issue of local manufacturing, especially just looking at healthcare commodities, medicines, usually I think all governments always say we'll support local manufacturing, then as media we report government will support local manufacturing. Have we gone beyond that statement to ask, what does supporting local manufacturing mean? We have to think about it from a business. The pharmaceutical companies, last I checked, there were 35 pharmaceutical companies in Kenya that manufacture medicines. They're in business. So has government assured them of a market? And we are talking about here. They manufacture here, but government and other players import. So the policy probably should shift towards making sure that hospitals in Kenya use locally manufactured medicines. There are those that are not locally manufactured, but diabetes, hypertension medicines, and if you check the locally manufactured medicines for a month's dose of diabetes, would be like 500 shillings. But when we import, we are paying around 5,000, almost 10,000 shillings. So there's need for government to move beyond supporting local manufacturing and making sure that there are policies that, one, assure the local manufacturers of the market. Secondly is, how is that policy environment? The tax regime, the tax policies are changing year on year. As a business, if I'm not able to look and forecast over the next 5 years, then I'm hesitant to put in investment into anything, because if next year my taxes are going to go up, and I'm not sure, then I'm not willing. So we need to ask, what is the tax policy and tax regime looking like for local manufacturers? And then, of course, the issue of energy is a whole other conversation, because if your energy costs are always changing every 14th day of the month, then it means I'm not assured, or I don't have a predictable business model. Then it discourages local manufacturing. Not health workforce, I'm used to being in health a lot, but the human resource is there. We are training people every day. We are training biomedical engineers, we are training engineers, like every other day people are graduating. So the workforce to work in these spaces are there. But those things that don't assure investors of money, then we'll just be talking about local manufacturing without actually moving it into action. And the onus is on us to move beyond those statements and actually look into what does it take, and is that actually happening?
Okay, thank you.
Thank you.
Questions for Dr. Akwale or Dr. Mercy? Any more questions? Yes, question. Oh. Okay. As a health practitioner and journalist, where is the gap on effective communication of health issues in Kenya? Both parties often take a more reactive approach than proactive or preventive approach.
So I'm usually caught in between both worlds. So let me start from media side. Health is complex, even to those of us who are in health every day. It's a complex story to report, because there are very many things. Let me use SHA as an example. I see stories about we blaming SHA because hospitals don't have medicines. But if you think about it, it is not the responsibility of the Social Health Authority for medicines to be in the facility, because SHA is one component of the health system which is on health financing. So it's just about making sure there's that finance. It's somebody else's responsibility, on the other hand, to make sure that the medicines are there. But there is an interconnection, because if the money doesn't come, then somebody else doesn't have medicine. But what we've been told here, people are always procuring every day. So there has to be money somewhere for that procurement. So are we following up for procurement 10 years worth of mental health medicine, yet children don't have antibiotics? Are we asking those questions? Because if you had money to procure medicines for non-essential things, then it means you could have actually used that money to procure for essential stuff. So it's about understanding what each component of health plays in, what it does and how it relates to the other. So it's always complex. So for us as media, it's about understanding those different balls that are always in the air and how they are interconnected. So when we don't understand, then we report something else, and the power of the pen, the power of the microphone, that's what people go to. So what happens on this other end, then they react. And they say, gazeti ya kufunga nyama, this media, they don't know what they are reporting, and then they leave it at that. So we are always at loggerheads. So my thinking would be, one is media is to take time to understand some of these things. I know our newsrooms don't afford us that. You're here today, by the time you go back, you're expected to have a story that goes to the newspaper tomorrow, or has gone online, you know, or go to the news. So you may not have enough time to think about things conclusively or completely and understand some of how they are interconnected. So it's up to us to understand that. And for the people on this other side, is to also understand that we live and breathe health every day. If you're in the health finance, some things are obvious to you. So it's to be patient, understanding, and explain things well before things have escalated and people are at loggerheads. It's just to take time and, you know, communicate. Like, for example, in this meeting, I was hoping, you know, the people invited from all of these other government arms would have been here, because then they would have taken time to explain some of these things very well, so that at the end of the day, there's no blame game. But the other thing, and we were discussing this with Dr. Kwale outside there, is we have a low trust society where nobody believes what the other one says. I don't have a solution for that, but I don't know what we'll do about it. But we have to start somewhere. And I think if we are consistently, as media, reporting objectively and the right thing, and having all the voices that Maxi talked about, the lived experiences, the policymakers and the influencers, then we start getting that trust that we once had, and we start getting it back from our audiences and from the society.
Okay, thank you very much.
Thank you very much.
Dr. Masikori.
Thank you.
You can take your seat. I have a question for you. This is from another journalist, and he asks, have we gotten a replacement for funding for malaria in Kenya? If not, where is your concern, or what is your concern?
Yeah, the question is, have we got a replacement for the funding for the efforts towards malaria control? The answer is there's progress, but still there are gaps. I know the Global Fund just communicated to countries indicating reduction. It is not as severe as we expected. They retain a lot of the essential commodities, the beds, the medicines, and what you would call emergency responses, like campaigns against potential epidemics of malaria. That has, to an extent, been retained by the Global Fund. But the indication is things may not get better. And that is why there is now discussion on this potential way forward, the issue of public-private partnerships that we've discussed here. But I really like also what Mercy Coril has talked about, co-investment, looking at the overall trade infrastructure, moving from aid to trade, and therefore the areas of co-investment. That is going to be very, very key. And then I think in this country, the opportunity of universal health coverage, trying to really come up with packages that are covered, and also moving away from just curative, and also looking more at the preventive aspects. And in fact, when you talk about media, I follow radio health programs and some of the TV ones, and you'll find a lot of attendance when it is medical treatment. But so you want to be told how to treat diabetes, but not how to prevent it. So that shift by the media, if it can really take people and say, we can actually have a situation where treatment doesn't come, where you don't need dialysis, not how dialysis is done. That should not be the big news, how to prevent the journey towards dialysis. So really for me, first, that is what I wanted to add. Yes, but for malaria, from where
forums. Anyone else, a topic that you would like us to organize for and call in experts? Yeah.
Good afternoon. My name is Amondi Aroko from Tuko Media. I think ACD is a big thing.
Okay. Non-communicable diseases. One here.
Good afternoon.
Afternoon.
My name is Derek. The main, you can focus on medical forecasting.
Medical?
Forecasting.
Oh, medical like forecasting of diseases or?
Forecasting.
What is that? What is that?
Forecast.
Explain.
Explain a little.
Like medical camp.
Like
Huh?
medical camp?
Medical camp, medical forecasting.
Oh, okay. Medical camps.
Explain.
As journalists, are these to be organized for journalists or as a discussion? Or we can take it offline. I'll come to you for details.
You could have just explained.
Well, I think I'd introduced myself earlier. An area that I'll be interested on is mental health. I think it is turning out to be a key area of focus with this Kasonga economy and other issues kindly considered, because I'm told in every 5 people, you never know there's some mental case. So how many are we here?
Okay. Anyone else?
Thank you. My name is Henry Owino. I'm a health journalist. I report health. Now that Dr. Mercy Correll is here, she has been a reporter, is also a doctor. I'd like Editors Guild, if possible, to organize a workshop so that you can train journalists how to report on these health matters. It's a big problem of the experience I've had. There are journalists who, okay, some doctors, some scientists and these doctors, they talk their jargon language. Of course, some of the journalists will not understand. Those who are experienced like us will simplify to the audience. So if you can organize with the doctors and journalists so that you train them on how to report health issues, I think the audience and any other person will understand what doctors normally mean. Thank you.
Then I think, yeah, we are just about to wind down. I want to thank you very much. You've been an awesome audience, very engaged. And I'll hand over to the CEO of Kenya Editors Guild to wrap it up for us. Thank you.
Thank you. We're supposed to do a vote of thanks. And I'll call upon Agnes Wangange, who is a council member in charge of radio, to give a vote of thanks. Then we are all invited to lunch after that.
Good afternoon.
Good afternoon.
Good afternoon once again.
Good afternoon.
I know a good number of us have left, but the number that is there is still a good number, right? So it's a big honor for me to be here, to be giving this vote of thanks. As a member of the Kenya Editors Guild, I am the council member for radio. And what I would like to say is that we are incredibly delighted and grateful for all our visitors, not visitors, experts, our speakers, those that have been very monumental in running this conversation. It's a great conversation, and I guess it's one conversation that we will continue having because we are yet to get a solution to the cuts, and as it is, as we have heard, we do not have a solution yet, but the solutions are there. I was very intrigued to learn about the manufacturing company that Dr. Mercy Correll was talking about. And I think I want to call upon journalists to do a story around that and probably just bring it to the fore. so that we can inform Kenyans. Because I realize that many times we miss out because we do not inform the public. Going back to what someone who stood here and talked about having visited a health facility where they pay 20 bob to get services. I do not know how many people have that information. And many times we fail because the information is not out there. So I think we have a good opportunity as journalists, and especially from this forum, to channel stories around what we have learned. These are great insights. I would also want just to speak on the, not speaking really, just touching on the challenges. I leave this place feeling way better. In the morning, I think when I was coming, and especially at the mention of these ODAs, you know, the cards, we are feeling like, oh my God, everything is lost. But I realize everything is not lost. We have solutions within. And I think we can build on them, and we can champion them, and we can even, you know, like share them and see where we get, so that we do not look like we are hopeless. Like all is lost, and like our country now is going to die. I mean, all these people are going to die, and we have no solutions to all this. So I think this is a great opportunity. So on that note, without much ado, I want to thank all our guests. I begin with one, Dr. Githinji Gitai of AMREF, the CEO. Thank you very much for your great insights. Dr. Eric Gitau of Development Dynamics. Dr. Rose Aronje of AFIDA. Dr. Willis Akwale, the Special Advisor to End Malaria in the End Malaria Council. Dr. Mercy Korir, thank you very much, the CEO of Willow Media. And our MC, Anne Mawad, the AIC of D Frontera. Thank you very much for your time. And without forgetting, I also want to thank KEG for mobilizing, for making sure that all of us were here. And for the rest of us who made time to be here and stay with us until this very moment, I just want to thank all of you for coming. And maybe that next time we also have a forum like that, like this, we also want to invite you. One more thing, the Kenya Editors Guild has its annual convention this year between 26th and 30th of November. It's going to be held in Kilifi, and we just want to invite all of you, especially the specialists. It is a moment of networking. We give training opportunities, and it's also a time to tell us what you do. So I just want to throw this out there to let you know that you are invited, you are welcome, you can come along as partners. We'll be very glad to have you. Thank you very much.
Naarifiwa kwamba your lunch vouchers are with Annie of KEG.